Hello, everyone. I'm Michael McNutt, WEDI's Vice President of Education and Marketing, and welcome to a WEDI Spotlight, navigating from fee-for-service to value-based care, data exchange, and the power of provider-payer partnerships. Before we begin, a brief look at today's agenda. Fantastic collection of healthcare professionals talking about the importance of data interoperability, technology, and partnerships when it comes to value-based care. Before we begin, allow me a couple of minutes to talk a little bit about WEDI. Formed in 1991 by then Secretary of U.S. Department of Health and Human Services, Dr. Lewis Sullivan. Our role at WEDI is to convene, collaborate, educate, and influence through our 18 HIT-focused work groups, education pieces, member position advisory, and a lot more. We also have a fantastic, productive working relationship with government entities such as ASTP, ONC, CMS, and OCR. Briefly mentioned the 18 work groups. Payment models work group is one of them. Work groups are the lifeblood of WEDI. Volunteers, members who are members of WEDI, provide thoughtful leadership and common sense approaches that enhance the exchange of clinical and administrative healthcare information. For more information about our work groups, visit wedi.org. Today's work group hosts are the WEDI's Payment Model Sub-Work Group. The co-chairs are Michael Patwell, Principal Business Advisor with EDIFX, and Brian Wallace, Vice President of Data Analytics and Reporting for Centene Corporation. Unfortunately, Michael could not make it today, but I'd like to introduce Brian with a couple of words about the work group.
Hi, everyone. Thanks for joining. Our work group's mission is to foster the adoption and implementation of new and existing value-based payment models by identifying technology attributes of these models, such as connectivity, eligibility and /enrollment reconciliation, payment reconciliation, quality reporting, care coordination, data exchange, as well as usage challenges and barriers to the implementation of new payment models. We do meet the fourth Tuesday of every month at 3 o'clock Eastern. So if you are interested in joining, love your participation, please contact Ariana Poole at apool@wedi.org.
Thank you, Brian. Ariana's information is below. Once again, apool, Poole, at wedi.org. WEDI work group participation is available to WEDI members. You'll hear from Brian today, as well as our other moderator, Denny Brennan, Executive Director of the Massachusetts Health Data Consortium. Just a reminder before we begin now, to ask your questions or a comment, please use the chat feature on your Zoom toolbar, and that the slides and recordings will be emailed after the event. It's my pleasure to hand this off to Denny Brennan with the Massachusetts Health Data Consortium.
Thank you, Michael, and thank you for assembling such an illustrious group of professionals and panels for our benefit today. This is a very exciting topic. We're seeing value-based care and payment models advancing in their sophistication, their precision, and their effectiveness. And we're privileged to listen to folks who are on the front lines of making value-based care a reality. I think Brian did a minor disservice to himself and the members of the Payment Models Work Group. This is tremendous work, and we couldn't be, as Michael mentioned earlier, where we are without the work of our work groups. To get us off and to get us started right away, I would like to welcome Melanie Matthews, who is the president of Multicare Connected Care and the CEO of the Physicians of Southwest Washington. She's also the incoming board chair for NACOS, the National Association of Accountable Care Organizations. And without further ado, Melanie, we'll turn it over to you.
Thank you, Denny. I appreciate the warm welcome and the opportunity to talk today. First, I'd like to share that is very much with a heavy heart that I'm presenting to you today. There was a very unfortunate passing of Jeff Mickles, who is the incoming CEO and was expected to start yesterday at NACOS. And so I extend as well to my thoughts and prayers and healing for Jeff's family, who he absolutely adored. And he was tremendously passionate about healthcare advocacy and was really looking forward to the opportunity to speak to your WEDI group about how important data is for value-based care. So with that, I will do my best to represent Jeff today. I serve as as indicated, I serve as the CEO of PSW, and the president for Multicare, Connected Care, and the value-based contracts and accountable care organizations out in the beautiful Pacific Northwest. And as an incoming board chair of NACOS, I've been a member of value-based care and all of its forms and iterations of models since the inception of the CMMI Payment Model Center. So we've been in the value-based space convening total cost of care contracts sort of since the inception. So we've had a lot of practice and we've learned a lot what to do and we've learned a lot what not to do. But I will tell you that value-based care works. And none of the value-based care magic works without the underlying data that we need to make that improvements in cost and quality possible. Medicare really set the stage by being the first real payer that provided a full claim set to accountable care organizations. This allowed us, although it was monthly, it did allow us to identify gaps in care, as well as identify patients with high and rising risk, so that we could stage an intervention for care management, chronic care management, specific disease protocols, as well as connect patients that needed resources, including in the community, by having that data. So we feel like that data is absolutely key. We know that in population health, accountable care organizations are really responsible mostly for total cost of care, depending on the Learning Action Network level of model that value-based entities participate in. But we really have a lot of different, I would say, competitive organizations and use cases for how not just standards are built, but we have a lot of homegrown registries. We have a lot of different patient portals and access points. We have different versions of electronic health records, which makes discrete file exchange challenging. And we really applaud the work that WEDI is doing in helping convene and be part of the solution as we identify ways to have the data where we need it at the point of care and allow us to have the opportunity to best manage the patient. So we're really an advocate, and I know you'll be talking about that today, and in multi-stakeholder groups around identifying and adopting a set of standards. And so we think that there's still work to be done, and we feel like we want to engage the industry on the pop health side from the users, the operators, to continue to encourage and partner with advocacy organizations and stakeholder groups like yours at WEDI. And we are very supportive of the TEFCA, the QNs, and the importance of the critical necessity of having the healthcare information exchange. So we're very much in support of that work. We need the data so that we can be more effective. And we need to have open source and interoperability standards that allow us to do it in a way that doesn't break the piggy bank. It's always hard to build the will and to be able to finance a lot of the information and infrastructure that we need to be successful in value. So we suggest that there's standards in healthcare versus the silos in healthcare, and really ensuring that we're having multiple use cases considered as standards are adopted. A little bit of an example of this is quality measures. Like, we all know that hemoglobin A1C is something that we need to keep our eye on, and we all agree makes great sense for a measure. But what source that data comes from and what is the denominator and standards can vary from payer to payer and product to product. And what we would really encourage is, how do we have data, how do we get the data, and how do we create a measure instead of so many measures at the same thing. I would also share that that provides frustration and abrasion from the sharp end of the stick, where providers do not want to have to do different standards and find different data for the same thing at the provider level. We all know workforce burnout and physician shortage is really a critical issue. And I think we need to really be mindful of what would be helpful for the provider at the bedside. And one of those is having the data standards and having a common set of measures. So if we can get this right, we're really going to transform accountable care. And the way to do that is really collaborate upon the experts on the data, the regulatory ONC and other rulemaking entities, and really engaging with stakeholders. We strongly feel that accountable care organizations serve a critical role in advancing that agenda, and are encouraged to continue to engage in the dialogue that needs to happen as we are developing those standards. NACOS will continue to be engaged and support this work. And I would just say, as I started to say, that value is working, I'm going to end with saying that there's bipartisan support for value-based care. And the industry has already saved $22 billion just on the Medicare Trust Fund since the inception of alternative payment models. So we expect to fasten our seatbelts and that this work will be accelerated in the coming years, and delightful to be able to participate in this work with you. Back to you, Denny.
Thank you, Melanie, and thank you for that overview. We are thrilled to bring other participants to the table today. And I would like to turn it over to my colleague, Brian, to introduce our next panelists.
Thank you for that, Melanie. Our next session is From Innovation to Integration, the Future of Value-Based Purchasing. And to discuss that, we have with us from the Catalyst for Payment Reform, Andrea Caballero, Program Director. Vice President. Andrea?
Thanks so much for having me. And I too would like to extend my condolences to Jeff's family, to the HCTTF team, NACOS, and all of his colleagues and friends. Thank you for having me today. I'm Andrea Caballero, Vice President of Policy at Catalyst for Payment Reform, and I'm going to talk about how value-based payment started. I know it sounds to be a little bit of a history lesson, but it's intended to kind of walk us through where we were, how we're tracking it, and where we actually need to change and transform, and how data fits into all of that. Just a little bit about CPR. So CPR is a 501c3 national nonprofit organization. We are a member organization. And our mission is to produce higher value healthcare for employer purchasers and to improve the functioning of the healthcare marketplace. As our name suggests, Catalyst for Payment Reform, as we think that one lever to improve the functioning of the marketplace is through value-based payment and payment reform. Internally, our members, we have peer-to-peer learning about various practices that employer purchasers are employing, deploying. And externally, we look to drive change in the marketplace, either through purchasing practices and policy support. So we're finding ourselves in much more of a policy position these days, given the activities both at the federal and state level on payment reform and price, which I'll sort of get to at the very end. So if you go to the next slide, I've been working in healthcare policy for about 25 years. And when I was starting my career, we've always talked about how America has the best healthcare, but it's too expensive. And I think in lots of ways, we still talk about it being the best healthcare in the world, and it's still too expensive. But there were a few things that happened in the early 90s and 2000s and new research that emerged that really called into question the, are we really the best? Are we getting the best? So of course, I'm sure everyone's aware of the To Err is Human. It highlighted the fatal errors occurring in hospitals, and it really highlighted the need for patient safety and looking at patient safety, measuring patient safety. Then there's the article by Beth McGlynn that highlighted that patients may not be receiving necessary care, and it forced us to rethink about care delivery. And then in 2003, we had the Crossing the Quality Chasm, which also introduced another way of thinking, which introduced the acronym STEEP: safe, timely, equitable, efficient, and patient-centered care. And so with these new research at the time that the system was not working, this led purchasers who were paying for most of the care for working people in America to pay differently and to tie it to value. So I would say that purchasers were most eager to make this change as they were paying for it, but the baton, was quickly picked up by government and health plans with the goal of connecting economics with quality and better value. So if we're going to have a value-based purchasing on the next slide, we have to define what it is. And I think we all have sort of seen this equation before, that value is quality divided by cost. But there are different elements that go into quality and different elements that go into cost. And on the quality side, and Melanie mentioned, there are a lot of different components, different measures. I have a slide on that, which I will run through quickly, but on quality, we want care to be delivered that is recommended by evidence. Are patients getting healthier? What is their patient experience, which is harder to measure? Are their preferences being considered? And of course, equity. Will a patient get the best care regardless of their personal situation, their age, their gender, their race, their religion, where they live, et cetera? On the cost side, there are also various ways to break this out. Typically, it's price and utilization. In utilization, we're avoiding services that don't improve care, or we're not duplicating services, and helping patient avoid poor outcomes. But the bottom line is that this is the model of how do we improve quality and manage cost, and the sort of the premise of value-based care. On the quality measure side, as Melanie said, and on the next slide, there are a lot of things that in a perfect world we would want in quality measures. Are these measures reliable? Are they accurate? Are they easy to collect? I don't even think I have on here the list that is everyone using the same measures, and what are the standards that are different? Why are they different? What is the data lag time between provider performance and measurement, and making sure there's that feedback loop? So all of these things in a perfect world would, be our perfect quality measures, but we know that this does not exist. But in value-based payment programs, and the designers of those have to balance the needs and these demands on, good, solid quality measures, albeit not perfect, and develop a value-based payment program that is, the best approach that they can with what there is. So how do we connect the quality to the payment on the next slide? This is really where the federal government, Melanie mentioned that, the baton about almost 10 years ago now was picked up by the formation of the Healthcare Payment and Learning and Action Network, where we were moving away from fee-for-service into payment that is linked to quality. And so this is the framework that the HCP LAN uses to connect quality measures to payment and economic incentives. Moving from left to right, fee-for-service in the orange column, there's no link to quality. And then as you move toward the left-hand side, each column there has different levels, I would say, of either tracking quality or measuring quality and how it's linked to the payment. And as you move to categories 3 and 4 and population-based payments, providers are taking on more financial risk, but there is also greater financial reward with high quality performance. And so this is a widely used, well-known framework to at least measure payment and what payment is linked to quality. So if you look at the next slide, this is going to show you the adoption of value-based payment. This does not show what's in category 1 and 2, which one is just fee-for-service. The majority of our payment still is in fee-for-service, but different market sectors are moving along that continuum. And CPR, I personally have been measuring the adoption of payment reform since 2012, 2013, and the HCP LAN picked this up in 2015 and 2016. What you see on this slide here is what was in the sort of bottom half of the green column on the prior slide, and the purple column, and then the full green column, population-based payment. And so this is what we refer to as downside risk in payment reform. And so there's growth in downside risk value-based payment arrangements in all sectors, but it does vary. And you can see certain sectors have faster growth or were sort of ahead, if you will, when we started measuring. Government programs like Medicaid and Medicare, they can see some of the greatest movement year over year because it's somewhat of a top-down approach, and they can, say this is what the program will look like, this is what the payment will look like, and the industry or the market will move. On the commercial market side, you can see that's in the red bar graph there. That's more of a bottom-up approach where you have contractual negotiations, and you can see some movement in the direction of adoption of risk-based, value-based payment. But compared to the other sectors, the commercial market probably has the most difficult time with that for, reasons related to negotiations primarily. So on slide 8, I'm going back to the role of employers here, and I said that they were really kind of they pushed for incorporation of value-based payment because they bear, primarily self-funded employers are bearing most of the risk here, all of the risk when they're paying their own claims. And they wanted better, and I think they realized that by not paying properly, they were part of the problem. So this led employers to work with their health plans and their TPAs, and this, really made the movement be embedded in health plan practices. There are ways that employers can work with their health plans. I know this isn't necessarily a purchaser audience, but we certainly encourage employers to talk with their health plans, their TPAs, to see how is value being measured? What are those quality metrics? Are they seeing improvement? And that data exchange sometimes can be very slow. Sometimes it's very difficult for an employer to see their own data. And so that's a separate issue. But employers are certainly now, with enhanced fiduciary responsibility, are very much paying attention to the data on their populations and how health plans are designing their value-based payment programs to address, either specific populations or general. This kind of led CPR to say, well, not a lot of standardization here. How do employers know that they're actually that health plans and their TPAs and others are actually creating value-based payments with, the best practices in mind? And I know there's a panel later that has worked extensively on identifying best practices. But if you go to the next slide, I just want to share with this group that we have been working closely with an advisory committee. NACOS and AHIP and others are on this committee where we've partnered with URAC, accreditation organization, to develop a recognition program for value-based payment, so that employers, the idea is that employers will be able to see if the value-based payment programs that are in practice with their TPA or health plan are meeting industry best practices. We will begin pilot testing this in late 2025, but at a high level, the principles that we believe are essential for being recognized best practices is that a payment reform program has to be patient-centered. There have to be very clear goals around patient care. The second is engaging providers early in the process and communicating with them timely and accurate data. We heard many times during our advisory committee meetings that the idea of bi-directional data sharing is essential. There are barriers to that, but there also are ways in progress that are looking to enhance that and reduce that lag time I talked about earlier. The third is the program design. And I would say sometimes payment reform can be a sort of separate module, if you will, within a health plan's portfolio of offerings. But the goal here to really maximize what we want out of value-based payment is for the payments to be integrated into health plan operations. So it's not a siloed activity, and it can be aligned with a health plan's benefit offerings and their network design. So all complement each other to really get that value that we're all looking for. Another principle is related to evaluation. So programs get designed, programs need to be evaluated to see if they're achieving what they set out to do. I know that on the health plan side, where I started my career, we expect clinicians to improve, and that data exchange is critical to that. But similarly, health plans, we want them to evaluate their own program and look at their own data and to see if it needs to be updated. So evaluation is a critical component of a best practice. And while equity has had a particular emphasis, I would say, in recent years, certainly the disparities were highlighted during COVID. One of the principles we believe is essential is that equity be built into programs at the program design level. So it's not we don't want it to be an afterthought, because there's a danger of value-based payment in that it could create incentives. If a clinician has a financial incentive to improve quality, there could be a danger that they only want to see healthier patients, because that allows them to achieve maybe greater outcomes on their quality measures. And so value-based payment programs need protections so that all patients are supported the same and treated the same. And so when we pilot this in late 2025, we hope that employers will look to these results of the best practices that health plans are using and factor them into their TPA or health plan choices. So as we move into integration, I talked a little bit about where we'd like to see that value-based payment is not an integrated, or it's not a siloed activity. At CPR, we really just would hope that we've been calling this value-based payment. At some point, it just needs to be payment. We're still in the, have a foot in the fee-for-service canoe, quite a heavy foot in the fee-for-service canoe. And the others are, on the dock perhaps. But at some point, we just need to recognize that payment does have to have value in it, and it no longer needs to be called value-based payment. It just needs to be payment. And integrating value-based payment into health plan operations is really essential in order for it to have its maximum benefit. As I said, integrating it into benefit design and the benefit design offerings to employer purchasers, integrating it into network design and care processes and care delivery, where the burden is heavy on the provider side, and where can the payment and standardization and integration into health plan operations across the board relieve some of that burden. And finally, the integration into information systems, which is core to this group here. I mentioned bidirectional data sharing was essential for the principles that we're developing. It's also essential for these programs to really work and work for the clinicians and the providers who are delivering the care. They need it's essential for data exchange in order for it to be working for the employer purchasers to know how these payments are affecting their patient population, their employees and dependents, and also for health plans to know whether or not the care is high quality, that their network is of high quality and is also efficient. So that's the that's kind of where we still have yet to be. We hope we get to just a payment, not value-based payment. But we still have one very large problem. And I don't like to end on downers, but if we go to the last slide, we've talked about the equation of value is quality divided by cost, and it was in the prior slide. Cost, you can say, is utilization and price. And I want to emphasize price here, that debates over prices and how high prices are, or how not high they are, is generally outside the scope of value-based payments and the discussion. But in order for it to be part of the equation for value, you can't ignore prices. And we definitely have a price problem in this country. And until we solve for price and understand how price and price variation until we can really get that under control, we aren't ever going to solve for the value equation. So with that, I will conclude my remarks and see if there are any questions.
Well, Andrea, this is Denny Brennan, and I have a couple of questions I'd like to ask you. Employers wield considerable leverage in negotiating the kinds of contracts they want with business partners, with trading partners. But the process of negotiating value-based arrangements, value-based contracts, or new models with ultimately with networks of physicians through health plans seems to be kind of hobbled, or I don't want to say stalled, but there's friction in certain places. There's friction between employers and those who design their benefits for them. If they're self-funded, there are restrictions that health plans that have when they're just doing administrative services and they're not managing the benefit portfolio as tightly as they would normally. And there's friction vis-a-vis providers who have mixed feelings about value-based arrangements and the lack of data and things that you've talked about. In your experience, where do you see, which of those or others that you know, because you know much more about this than I do, what should we be tackling first? Where do you see some of the major sticking points that, were we to do something different, we might see the biggest impact, the biggest increase in value-based arrangements between employers, health plans, and providers?
Well, I think you started out your comment by saying employer purchasers do have considerable power and leverage here. And when it comes to payment and paying claims, they have ceded that power to their partners. They have ceded the negotiation power to their health plans. They've ceded it to their TPAs. So I think employers getting smarter on, and we represent employer purchasers, and they've heard this from me, but employer purchasers getting smarter on and not ceding all of that negotiation leverage to other parties who may have conflicts. I think we will see bigger movement. I know there is friction where health plans say, well, employer purchasers don't want to, buy this product, or they don't want to take this value-based payment. And so that friction goes both ways. I do think that employer purchasers, there are those that are doing direct contracts, but we have to be real that is not going to be something that's going to get taken up on a widespread basis. The other reality is that employer purchasers, their benefit design people are not just managing health benefits. They are managing retirement benefits and life insurance and dental and all kinds of other things. And so their ability and their expertise to really get involved on value-based payment is limited. But I think organizations like myself, there are others that are CPR, and other business coalitions are becoming much more active in how to educate employer purchasers to be more involved in the value-based payment contracts because of the price issue. So I left with the fact that employer purchasers now, price is becoming their primary focus. And as a result, they are looking much more closely at the negotiated contracts that are being negotiated on their behalf.
Right. Okay. Thank you. That's really helpful. I have a second question, which is, part of the theme of today's discussion is about interoperability, data exchange, the ability of data to, better, faster, more accurate, more timely data is, sort of the gasoline that this car needs to get moving. Could you talk a little bit about, where would you see if we had today, and if your members today had immediate or close to real-time access to a host of quality metrics for the providers that are in the networks of their plants that are taking care of their employees and their dependents, what do you think if people had that visibility into real-time data today? What type of changes do you think they would implement first? What are some of the things that you think employers and health plans and providers would do to begin to improve value in healthcare, given the availability of good data?
Well, it actually has to start a step back from that, because right now I mentioned some of the friction between employer purchasers and health plans is that not all employers get their data. Or they get partial data, even though they're self-funded. There are contractual limitations from sharing their claims data. So until that problem does need to be solved, where it just needs to be recognized that this is employer purchaser data, therefore they should have it. So if we get there, what would employer purchasers do once they look at their population, the quality that their employees are doing? I think they would look at it against the design of their network and their benefit design. And if they could make changes in real time, I think they would. I think if it meant changing a copay so it could improve a quality measure, I think they would do that. I think if they could maybe eliminate high cost systems, but are low performing systems, they would do that. But right now, there are many contractual provisions between health systems and health plans that prevent an employer to even take that action. We have examples of that in the Northeast with 32BJ. But in the press, I can name them here that, that they were not able to take out a high cost system. So I think employers would do that. They would change copays if they saw quality data not improving, but if they could, get their employees or steer them to certain high quality providers if some other facility where they were going was being underutilized, or maybe the low performing is overutilized and the high performing is underutilized. I think it would change their steering tactics, which would go a long way to improve at least their own population and change. But people are very tied to their providers, so employers have to really think hard about how they communicate with their own employee populations that this is in their best interest, not against it.
Right. Well, thank you for that. I have many more questions, but I want to be sure I allow our guests today to ask what questions they have. Any questions from members of our audience? All right, I'm going to have one more question for you. Is Andrea, am I pronouncing your name properly? Is it Andrea or Andrea?
Andrea, the first way.
Andrea. Okay.
Yes.
So accent on the second.
There is an accent on the E. Yes.
Okay, I appreciate that. this is a complicated chain of custody, a chain of responsibility for, going from an employee through their employer to a health plan, through the health plan to a network of physicians, to individual practitioners who need to see how they're doing in order for that feedback loop to kind of perpetuate itself. And right now we're seeing high deductible health plans. We're seeing efforts to reduce the price, the cost of healthcare, but that's really a shifting exercise. And structurally, what you have posited is that if health plans had access to claims data, for example, I just raised that as, in which in some cases they don't, in some cases they do, or if employers had access to really good provider data, tell me who the best providers are in my network. There could be some significant progress made. When we look at interoperability and the move that has been afoot for the last 8 years or so to connect disparate systems, to break down silos, standards. I heard someone say standards, not silos. I think that might have been Melanie earlier. That is a really good sort of motto or a rule to live by. When you look at the regulations that are promoting a patient's access to their data, a provider's access to their data, the ability for people to have a greater degree of control over their health. Do you see employers starting to work directly with their employees to use some of this I think, for example, if I were an employer, I'd have an app. I'd have an app and try to have my employees know, here is our network of docs, here are the best performers. Keep trying to provide positive information support for employees and their dependents. Do you see that in among your employer members? Do you see some who are looking at interoperability and seeing a real opportunity to change this kind of chain of custody and get closer to their employees and their dependents and help them make more informed decisions?
I can say that we work with some of the most innovative and progressive, sort of ahead of the curve, or tip of the spear type employers. And so the answer for our membership is yes. I think they really are trying to get much more to really close that gap between the information that they might receive from their TPA and how that translates into actual member behavior or employee behavior. The other thing so I do think, yes, employer purchasers, maybe not generally and widespread, especially in a fully insured situation, but on the self-funded side, I think that is happening. I also think it will happen, and it needs to happen because employers know that and we've got plenty of lawsuits out there now in terms of their fiduciary responsibility. And so being able to really connect the dots with the employees that they are spending their healthcare dollars in the most high quality and cost-effective way, that is going to definitely have to close that gap. So employees know that the employer is working and spending those dollars in their best interest. It's a long, employees are communicating with them is certainly an art about why they should transition. There's a lot of stickiness with their providers, but I think the more employees know about the price of their healthcare services that their employer is paying, and that the higher the prices, the wages have not, they have been stagnant or they have not kept pace. And so I think what we see a lot more is that employers are trying to connect the dots that what we are paying for your healthcare services is eating into anything we could give you in terms of wages. And so the awareness is there. Doesn't totally answer your interoperability question, but I think—
No, but you're pointing to some underlying, structural issues that are really important to understand before we can start talking about connecting.
About apps. Yeah, right.
Yeah, before we can start talking about apps. Janice Karen has a question. She asks, has there been any employee feedback about being uncomfortable with employers knowing as much as they could about their use of healthcare? Is there an employee-employer challenge here or an impasse here about why health plans don't necessarily share all the claims data with employers? Are the employees, where do they sit on this? I could see some saying, I'm all for it, and I could see some saying, no way. What do you see in your experience?
I think typically the data that an employer receives, if it does, is de-identified. So it's not associated. It's for their employee population, but it's not. It does not have individual names on them. So certainly privacy is, whether that is an actual issue or a perceived one. I think, employers are sensitive to the privacy of their employees' data, and that individuals within a executive suite, for example, don't have all that information. So I think when employers do get data, it's at the claims-based level, but not with it's de-identified. But it's not to say that that's not a real issue from the employee perspective. I don't have data or direct experience saying like this is a. I think it's more of an issue when you get into fully insured smaller business and smaller firms. There are always going to be those, the NICU babies or the heart transplants or things like that, and those are hard to hide in terms of who it is and who it isn't. But in general, I think employers are very sensitive to that and try to only look at de-identified data.
Well, Andrea Caballero, Catalyst for Payment Reform, thank you so much for this discussion. This has been very valuable. We appreciate your sharing your perspectives and insights with the WEDI community. Brian,
Thank you for your questions.
Absolutely. Brian, I'm going to turn it over to you for our next panel.
All right, thank you. Our next session is enabling the seamless sharing and integration of health information across different healthcare systems and providers. To discuss, we welcome Danielle Lloyd, Senior Vice President of Private Market Innovations and Quality Initiatives for Clinical Affairs at AHIP, Aisha Pittman, Senior Vice President of Government Affairs at the National Association of ACOs, and Christopher Botts, Senior Manager of Care Delivery and Payment at the American Medical Association.
All right, good afternoon, everyone. I think I'm kicking us off here. So we are here today, if we go to the first slide, to talk about playbooks that we created around with the goal of advancing value-based care across all lines of payers.
Hi, Aisha, I don't think I have the slides.
Oh, okay. We can work on getting those to you while I kick it off and talk a little bit about the overview. So
Great.
AHIP, AMA, and NACOS came together to, with a recognition of value-based care is not just happening in traditional Medicare. I think when we see metrics around the success or challenges in value-based care, it's very much referring to models that are focused on traditional Medicare. So the ACO programs and then other models tested by the Innovation Center. But so much around value-based contracting is happening outside of traditional Medicare across all payers. And we wanted to highlight what's different and what are the best practices that are occurring across a landscape of payers. And so our three organizations came together and created playbooks that highlight voluntary best practices for adoption of value-based care arrangements across all lines of business. And I emphasize the words voluntary best practices because this is not a follow by each step recipe. This is more we have to understand that each situation, each market is a little bit different. And so we really see these playbooks as a suggestion for folks and a list of things to think about as you're engaging. Our goal was really to highlight what works best in order to advance adoption. And our audience was just thinking broadly about all of our members or other folks who are interested in pursuing value-based care arrangements. We took a really in-depth approach to develop these playbooks. We did some subject matter expert interviews. We did an environmental scan, a literature review, and then created advisory work groups comprised from members of each of the 3 partner associations. And I must say, these work group discussions were really rich because we got into the details of where there is misalignment between providers, the accountable care entities, and payers, and where we see ways to create solutions so that we all can work better together. And so how we really see these playbooks is, as I said, sort of a voluntary checklist across both. We're going to cover 2 playbooks. Across the 2 playbooks, there are over 150 best practices. And so we, recommend folks take that and think of these as like a checklist of, is this something that you should consider? How would you think about implementing one of these voluntary best practices? And we don't necessarily see this as static. While we don't have any explicit plans to update the playbooks in the future, we are very much planning to we are seeking feedback from those who are using the playbooks, and that will inform our future work. I'll note that across the playbooks, we also try to highlight and provide spotlights of when those best practices are in action. And so we have several spotlights throughout the playbooks focused on ways that those best practices have come to life. And for the slides, now that they're up, we're on slide 7. And so, as I mentioned, we're going to go through our 2 playbooks. In last year, we released a playbook on data sharing. And then this year it was on the payment methods. And I think there's some, real common themes across these 2 playbooks. I think one overarching theme is collaboration and flexibility, always meeting folks where they are, and really to enter into a value-based care arrangement, it's a partnership between payers, the providers, the accountable care entities. And so, fostering the best collaboration, and also the best collaboration comes with transparency. And so transparency in many different ways, from being very upfront and transparent of what the shared goals are, but then also the details around methodologies and timelines. And so with that, I'm going to turn it over to Danielle, who's going to kick us off in talking about the first playbook on data sharing.
Great. Thanks so much, Aisha. And I want to echo the words of partnership, both among our entities, AHIP, AMA, and NACOS, but also among our members represented on the work group. And as well as we go on this roadshow, it's been really great to see the different parts of the healthcare system come together to seek to advance value-based care. So I'm going to cover this first chapter that Aisha was mentioning, that's on data sharing. We thought this was a good place to start because there's essentially universal agreement that access to timely, actionable, and accurate data is core to the success of value-based payment arrangements. So you sort of heard the theme throughout. I'll note that we include both best and promising practices, as you can see here on the slide. In this case, not all of the technologies are in daily use, not all of the standards are completely final, etc. The other thing I would just point out here is that the link to the playbook itself is included on this side. We urge you to look at additional details. So let's go ahead and move to the next slide. There are 5 sort of major overarching categories for these best and promising practices that address data interoperability, comprehensiveness, ability to reduce disparities, timeliness, actionability, transparency. And within each of these, we go through and we list out some of the challenges, some of the best practices, a little bit about sort of which value-based care participant might be working in this area and adopting the practice, where it might be applicable. And then we have sections on what are other considerations. Certainly, if you are a WEDI member and on this call, you know more than the average bear on electronic data interchange or exchange. So some of this may seem somewhat basic to you, but remember our audience for this really is far-reaching, from organizations that are just starting out, could be, a small physician group who's just choosing to come in one of these models, could be payers who haven't offered value-based care models before, through to maybe a large, a provider group who has a percent of premium contract with, a payer that's been doing this for a decade now. So we try to have something sort of for everybody across the journey throughout this. And some of it is, sort of the basic level, the medium level, and then the heavy level. So for example, in the appendices, we have references to the different standards development organizations and particular standards that might go with best practices. So just to give you a little bit of an orientation on kind of how it's set up. So if we move to the next slide here, the first area of best practice is creating an interoperable data ecosystem. And when it comes to data, as you all know, we need to be speaking the same language, and the systems need to be able to interface. In the case of value-based care, there's lots of different reasons to exchange data. For example, the payers need information from the providers to calculate quality measures and financial benchmarks and such. The providers need information and returns that they can ingest and understand and act on for their participation to be successful. And for all of this to happen in the most efficient and effective way, you need the adoption of standards, content and exchange standards. And the report walks through different options in terms of using standardized data sets and data elements to facilitate data sharing. But it also points out, in terms of those challenges that I mentioned, that not all of the standards are final, not all of the implementation guides are mature, the data mapping, etc., which can impede interoperability. And an example that was given during the process is, for example, you might have an accountable care organization that has many disparate physicians and hospitals that are part of it. And so aggregating data across those different organizations can be very problematic because they're using different electronic health records. Not everything is standardized, etc. Other important factors that were identified include defining data governance and management practices very clearly to engender trust and ensure privacy. All of this, at its root comes back to building trust between the payers and providers and other stakeholders in the ecosystem. So the transparency piece is something that's come up across not just the data sharing, but also you'll hear from Chris in the payment systems section as well. Leveraging existing exchange networks to minimize costs and burdens, the use of health information exchanges, etc. The idea of being able to have one data use agreement, one technical connection, and being able to access broader data reserves is important from an efficiency perspective. Another is leveraging new technology like APIs, which I know most of this group are familiar with, but certainly is in the sort of burgeoning category that really shows promise for improving access to clinical data and other forms of data. plus the advantage of, as we move forward in the future, the ability to query for an element of data as opposed to a broader document that might have more things in it, something that organizations are looking for in the future. Ensuring that the systems are updated regularly. As we just finished the election, we're heading into a new administration. There are, of course, always changes from the regulatory perspective. Some of this, even though we're largely talking about private payer arrangements, there are certainly implications. And finally, aligning to standards can enable integration in the workflow to the extent that things are able to be built into electronic health records or into practice management systems, et cetera. It's going to help, again, with that efficiency and success. And particularly, I know one thing I hear from providers about payers is we don't want to have to log into one system to get our data dashboard and then log out and go into the next payer's system. There's certainly some room for improvement in that area. And then quickly, just in terms of some considerations here of being conscious about things that require manual edits and new EHR configurations are certainly can be expensive. Considering the best methods for sharing the data, and we're going to talk a little bit about that on the next slide. So I'll kind of skip past that, but the potential use for exchange frameworks. We've had mentioned earlier by Melanie the notion of using TEFCA, the Trusted Exchange Framework and Common Agreement, or California, the California Data Exchange Framework, et cetera, that shows great promise moving forward to really facilitate value-based care. If we move to the next one, the second one is sharing more complete and comprehensive data. And the work group identified several things of importance, one of which was empowering participants, again, with that sort of complete, accurate, consistent data so that you can get that more comprehensive view of whether it's an individual patient or at a population level for that effective and efficient coordination of care. Sharing different types of data, not just claims data. This also gets into a little bit of the promising, but demographic data, clinical data, public health data, social determinants health, patient-reported outcomes, et cetera. A real interest in sort of that broader data exchange within the ecosystem. Sharing data at both the individual and the population levels, depending on the maturity of the organization. Sharing individual and practice level provider numbers. If you think, again, using an ACO example, if you have data across the entire organization, making sure that you're getting information sort of out to the right providers within the organization, because the providers may have billing privileges at more than one location. From the provider side, a note that if providers are submitting claims more quickly, payers will be able to get the dashboards back to them more quickly. So it's sort of not something that you necessarily think of going back and changing sort of an existing system. And that then the use of vendors can be beneficial. Some of the EHR companies, some of the practice management groups, can support more real-time automated electronic exchange of data. And on the payer side, sharing data ideally for services outside the value-based care entity is important, again, for that comprehensive view. Two of the considerations in terms of difficulties is patient matching is something that we're all still working on and can be problematic. And then variability in the credentialing process by plans and whether or not there are some streamlining that can be done there that will help and get clinicians enrolled and attributed within the value-based programs. We move to the next one. The third one is improving data collection and use to advance health equity. We thought about doing an entire chapter on health equity, but then we really thought it should be integrated into each of these So it really stresses, in the case of data, it stresses the importance of collecting and sharing social determinants of health data and demographic data to reduce barriers to care and disparities. And of course, making sure that the data is, that the use of it is transparent, that you're appropriately using the information, and that it continues to be kept confidential. Extending data beyond the clinical teams is also something that came up, that the community-based organizations, for example, really could benefit from having some of the information, and there are permitted uses under HIPAA. There's also another example given was national registries for research and public health, and additional data sharing in that area. And then, the use, getting back to one of the previous slides, the use of standardized data elements. So whether this is Z codes, link codes, now we have some G codes, for, ensuring that we're sharing information in a standardized way, and using validated assessments, the importance of having those validated tools, and finding ways within those value-based arrangements to incentivize the use of both the codes and the validated assessment tools. To the extent that there's an ability for payers to provide training and support around the collection of data, measurement, analysis, that was encouraged, certainly ensuring transparency with consumers to improve trust and autonomy from their perspective as well. For considerations, the need for more granular information around demographic data standards, that's actually something AHIP is working on in a separate work stream called the Demographic Data Element Modernization Initiative, or DEMO initiative, with 136 other organizations. In the next month or so, we're headed into the HL7 process to take the content standards that we developed and move it into FHIR-based resources. The second consideration was around the need to stratify quality measures, and that's something that has now been being picked up by the Core Quality Measure Collaborative, to give guidance on how, once you have this information, you can build it into the measures to identify the disparities. And then lastly, there aren't a lot of measures of equity. So access measures and such, sometimes it's not about disparities in care, but disparities in actually getting care. So that's an area that we all need to do some work. The fourth one here is share timely, relevant, and actionable data. We need to ensure that data can be leveraged to help inform clinical decision-making, and to do so, it needs to be timely, it needs to be at the point of care, and it needs to be curated, because you can't just dump a whole bunch of information on the clinicians there while they are seeing patients. To this end, we also talked about frequency of updates, ideally providing data from the payers to the providers monthly. And one of the challenges expressed by the providers was getting adequate information around attribution, or at least frequently enough. So that was another recommendation, was to provide that information more often. And another consideration is the form. This sort of has come up across the different buckets, but some organizations are able to receive massive raw claims data and work with it themselves, or work with a vendor. Others just need a dashboard and want, again, that more curated view. Some want both. So some of this was around the payers trying to meet the providers where they are in their journey, and providing them data sort of in the size and box that fits them, and providing training and support regardless of the type of information offered, as well as those incentives, as we talked about in the equity area, just in general, in terms of finding incentives for adoption of new technologies and data analysis. Last quick thing here is the leveraging the data sharing network. So that, as you can see, is also a common theme across them. So if we go to the final one, and then I'm going to wrap up so we can get to Chris on the payment side, is sharing data, methodologies, calculations, and context. And part of this is where I started earlier, that ultimately the success of these partnerships is going to be based on trust and the ability to build better trust between the organizations. So this best practice is really about providing transparency in all aspects of the value-based payment arrangements. For example, establishing the benchmarks ahead of the performance period, regularly sharing the performance data, and having the feedback loops to address any concerns that may come up with the data. And finally, sharing the reliability of estimates. And this is important to not only improve confidence, but also for planning purposes, to have a sense of how solid the numbers are. So, we did also think about what to do when complete data cannot be shared from the perspective of the comprehensive nature that we noted as a best practice at the beginning. There are, certainly concerns about sharing value-based or sharing payment rate data for organizations outside the value-based entity from a competition perspective. And, so I think part of this was, how do we think about this in the future where if you're a value-based care clinician, and you want to make a referral, well, how do you have a sense of relative costliness or other information that maybe isn't the specific rates of each of the other providers you might be referring to, but at least provide some guidance to those clinicians. So as you can see, there's a lot of, if we go to the next slide, a lot of best practices here. And I think we're one behind because we just passed 5. So there we go. There's not only a lot of best practices here, but there's a lot of homework as well. And this slide, we just wanted to officially recognize and thank those work group participants. And we certainly encourage you to look at more of the details in the document itself. And with that, I'm going to pass it over to Chris.
Danielle. Michael, if you want to go.
Chris, if you can just pause for a moment. I want to just ask Danielle one question, and then we'll quickly turn it over to you. You noted that there are some, bright lights in these partnerships and these collaborations in your comments. Can you share some examples, as much as you're able to, of organizations that are making these benchmarks actually happen, where you're starting to see these come into play in the course of business?
Yeah, I mean, certainly there are, and I will say I would say there's more spotlights or, bright lights, as you said, or positive deviance, however you want to call it, in the payment than there are in the data. I think partially just for, proprietary reasons. But I would say there are organizations out there already that are incentivizing, as an example, the collection of equity data that are providing upfront capital investments for things like technology acquisition in terms of data analytics. There's organizations who are providing large-scale population-based data files in advance of the requirements of CMS under the interoperability rules, implementing those population health data files. So there's a lot going on already in this area. I mean, I would also say, many of our members participate in the Core Quality Measure Collaborative, which is trying to align those quality measures so that there is consistency in the data. You don't get the results of one readmission measure from one payer and another readmission measure from another payer, and maybe one says you're doing well and one says you're not doing well, right? So I think some of this is trying to align around the content standards is, I think, a little bit further along the measure, align around measures. But where people really are looking forward to the biggest change is alignment in the use of the APIs to share information, being able to collect digital information for the quality measures that's already built into the EHRs and built into the workflow. So we don't have to do all of this chart chasing and and passing flat files back and forth. So I think we do feel like we're kind of just on the edge of being able to make some significant progress in this area.
That's excellent. Thank you very much. And Danielle Lloyd, AHIP, we appreciate your comments and your discussion. Chris, we turn it over to you.
Thanks, Danny. Appreciate it. And I know we want to leave some time for potential questions. So just for context, I think Danielle really did a great job of underscoring, right, the push and pull between the underlying capabilities when it comes to data sharing, but also how those interplay with the actual capabilities from these underlying payment methodologies within these arrangements. I will also say that the first playbook that Danielle noted had almost 40 best practices, and Danielle did a great job of highlighting a number of them. And then this playbook has over 50. So I'm going to go pretty quickly through a lot of these things to allow us to have some time for discussion. But I think it just shows the really breadth and depth of the work that we did with NACOS and with AHIP. So if you want to go on to the next slide. So just very briefly, similar to the first playbook, this playbook focuses on those underlying payment methodologies and really identifying many best practices across the board that really feel are essential for being successful in these types of arrangements. Next slide. In slightly different fashion when it comes to the data sharing playbook, we organized this playbook specifically around 7 specific domains. And I will also note that I think Andrea had included the slide from the land that I think many of you may be familiar with. If we did a playbook that covered all of those types of arrangements and the underlying payment mechanisms that are utilized with them, this playbook would be even larger than it already is. So as a strategic focus, our discussion really focused on total cost of care arrangements with the understanding that many, if not all, of the best practices and components, including transparency and code designs, all really apply across the board when we're talking either for bundled payments or episode-based payments or the like. There really is applicability across the board, but when it comes to just kind of this discussion, if you could put your total cost of care cap on, that's kind of the lens that this work group really focused this discussion on. So we spend a lot of time going through each one of these specific areas, and they're really critical. And frankly, there's interplay between all of them that really is essential. Cannot focus on one without the others when you're thinking about being successful within total cost of care arrangements. Next slide, please. So the first area is patient attribution. I'm not going to go through the definition of patient attribution, but it really is just really ensuring, right, that the right people are identified and included as part of the specific arrangements, and particularly ensuring that those patients that are included, that those VPC entities or participating practices actually have reasonable ability to coordinate and improve the care for those specific patients. One of the biggest item that was talked about as part of this discussion was around really trying to prioritize the voluntary patient selection and the patient preferences for who they want to see in terms of their care. And so really critical component as part of being successful in these arrangements. That being said, I think there was a lot of discussion around the abilities to actually operationalize that and the prioritization that different arrangements may have in terms of when and where to allow for that patient selection. But ultimately, it really was identified as kind of the gold standard when it comes to patient attribution. When you think about kind of more claims-based attribution methodologies, there was a lot of discussion around kind of prospective versus retrospective attribution, as Danielle and Aisha, we've talked about a lot. I think one of my favorite quotes coming out of the discussion is, I don't think folks expected to spend 3 hours talking about attribution. I think many folks thought this was kind of like an area that was pretty clear. And it was very obvious from our work group that that wasn't the case. So one example, just for prospective attribution, is ensuring that appropriate exclusions are applied at the end of the performance period, whether that be a catastrophic situation like a huge storm coming through or people moving out of the area, making sure that is applied appropriately at the end of whatever the performance period may be. For retrospective attribution, things like including provisional provisional data throughout the performance period to give the participating entities some idea of who may be attributed to them, as well as things like limiting quality measurement to only the first 3 quarters of a performance year, understanding that the last quarter, many of these participating entities really won't have a lot of ability to actually make any dents in terms of those measures. So those are kind of some of the things that the group had kind of identified. Moving quickly to the next group. This is just more kind of descriptions of the various different kind of patient attribution sections. One thing just to kind of note that we had talked about was, there are starting to be more strategies and methodologies to really identify who the principal clinician is who's managing the care, including potentially non-primary care specialists who in certain circumstances are actually providing comprehensive care for patients. So there's a lot of discussion of different methodologies to do that, whether it's including multitude of different types of CPT codes, for example, as indications of who may be providing that type of longitudinal care. There's a lot of nuance there to go into it and some examples in the playbook, but really just understanding that there are some ways, while it can be difficult, to try to determine whether it's not just primary care clinicians that may be providing that kind of longitudinal care, at least for a specific part of a performance period. Next slide. Benchmarking was another big issue for the group. And the topic of rebasing particularly was a huge discussion. And there's a huge difference between the frequency of rebasing in the kind of commercial space than what you may see in some of the federal or state-based initiatives. And the group really wanted to emphasize that avoiding too frequent rebasing is really a critical component of being successful to ensuring that folks aren't just being ratcheted off of their successes and really wanting to invest in their work, especially being able to move from historical to maybe regional baselines, which would allow for those folks that may be performing well within their own region to actually be incentivized to continue to do great work rather than being compared against themselves. Next slide. Other components I think talked about as well. Again, prioritization of regional versus natural trend factors. When that can be challenging for smaller plans, for example, in rural areas. But again, it really makes the data a lot more actionable and specific to the markets that are being serviced. Also finding ways to combine prospective administrative trend factors with retrospective adjustments can also help create more balance and predictability and accuracy when it comes to creating benchmarks over time. And then lastly, and I know Danielle talked about this as well, and the data sharing playbook, issues around health equity and historically marginalized populations and communities was really a critical part of this discussion, and just acknowledgement, particularly in this space and in many of these domains, that there continues to be a lot of work of how to really adjust and amend current benchmarking methodologies to better encourage the inclusion of these populations within those areas, whether it's just general acknowledgement that those benchmarks really haven't appropriately captured those populations, or even creating separate benchmarks for those populations to really help incentivize participants to actually want to facilitate engagement and access to services that those populations so desperately need. Next slide. Risk adjustment was a big area as part of the conversation as well. Really focusing on utilizing known risk categories like HCC or other independently verified models, really ensuring that targeted physician education and support is clear and clear ways of actually ensuring that these services are being documented appropriately. This is a really critical piece that helps really even the playing field across the different size of participants, as some may have more resources to put forward than others, really ensuring there's adequate engagement and education in this space is really critical across the board. Next slide. As I noted before, just very briefly, right, again, even in risk adjustment, again, I think there's a lot of work that still needs to be done to help pilot and monitor how adjustments should be made from a health equity standpoint in these models. There's some examples that are in the playbook, and I think there's some ongoing conversations and recognition that there needs to be more piloting done before these could be spread at a more national basis. Next slide. Quality performance is a different component, and this is a little bit separate to the number of measures or which measures, but just acknowledging that quality does impact the levels and amount of payment that is received within these specific arrangements. And really important to be able to establish a minimum threshold that can potentially scale over time, which helps reward higher quality improvement. This really creates aligned incentives rather than having a singular threshold across the board for folks. Different entities are in different places, have different populations, are coming from different places, and so having the ability to have a sliding scale can be a really helpful approach that really allows everybody to be engaged as part of that overall quality improvement journey. And as I think Danielle had mentioned as well, transparency when it comes to things like quality measurements, methodologies, performance targets are really critical to ensure that people can trust that these are the right measures and how they are being calculated is understood and agreed upon across the board by everybody that's participating in these arrangements. Next slide. Levels of financial risk was a huge area of discussion amongst the group, and there really was a broad recognition that if, how, and how much financial risk is assumed by those participating in these arrangements is really there's no one-size-fits-all solution there. And it really is critical to acknowledge that fact when approaching these specific spaces. But if there is an agreement that increasing levels of risk makes sense on both sides or on all sides of those engagements, that there are some really great best practices that were identified to help with that facilitation. One of which is just allowing entities to potentially even move back from downside back to upside only arrangements when significant changes are happening, or for example, there's additional increase in the benchmark when it comes to the inclusion of historically marginalized communities, and really just recognize, right, that this process isn't a linear singular direction discussion, that there's the opportunity to reassess over time to best fit the needs of the populations and where folks are as they continue to engage in these initiatives. Next slide. The next component we talked about was payment and timing of accuracy. There's a lot of discussion and challenges, right, of the amount of upfront investments and ongoing maintenance it takes to really truly be successful in these arrangements, and the difference between those efforts and when payments are actually received, right, can be over a year or even more from when those actions are taking place. And so it can make it really challenging for those participating in these arrangements to not only be successful in the short term, but also want to continue to invest and improve their efforts over time. So there's a lot of specific discussions about ways to help facilitate this, one of which is the opportunity, regardless of that payment timing, to include some forms of prospective payments where there are care coordination fees or upfront investment fees or payments, excuse me, that can help bridge the gap between when some of those payments may be received and the efforts that are going on a day-to-day basis. Next slide. The last component that we talked about and talked a lot about, and is a little bit of different flavor from the other domains, is the need to not just incentivize at the entity level, but also incentivizing at the individual participant level as well. And the difference is, you know, given that this is really talking about payment methodologies, really acknowledging in this space that Financial incentives are not the only ways to engage individual participants. And in fact, non-financial incentives, including, as Daniel noted in the data sharing playbook, access to timely, accurate data, ways to reduce administrative burden, increasing transparency, etc., can also be really critical to be successful within these arrangements. So again, developing clear objectives and criteria for distributing these incentives within these individual entities can be really kind of critical. And next slide also talks about, where appropriate, the ability to actually facilitate these incentives and engagement at the TIN level rather at the NPI level, which can really create a sense of camaraderie amongst the teams that can really spread these incentives across the board, including perhaps those folks that are at the front desk or others that are also helping be successful in these models, and can really create a sense of a team when it comes to participating in these arrangements. So I know I went through that really quickly. I went through, again, 7 domains and over 50 best practices in a short amount of time. But the next slide, similar to our data sharing playbook, just shows, I believe, this is the acknowledgement of all the great participants we had in the work group, which, as with the data sharing, we really try to focus on having a wide variety of perspectives, experiences, practice settings, geographies, to really show the breadth and depth of the types of folks that are participating in these arrangements, and really appreciate their time and energy for this work. So with that, I know we're already at time, I believe, Denny and Michael, but maybe we have a few moments to address any questions that folks may have.
We certainly do. We'll do our best to move through them as quickly as possible. But one of the questions that has come across the transom, and let me open my chat so that I can read these clearly, is Danielle, you talked about data governance principles. Can you give an example of a data governance principle that was central to your work, as data governance is so important to these efforts?
Yeah, I think we don't list out, we don't go that next level deeper and list out the actual principles, but sort of the act of going through that and tailoring the data governance principles to your particular organization and situation. But certainly it came up particularly in the equity space, in the use of demographic data as an example. It's also something that in the data sharing category, it's come up extensively around the use of artificial intelligence related to acquisition of data, bringing different disparate data sets together, how you apply AI, whether or not consumers know that it is used. So I think some of it is around the transparency with the consumers. Some of it is about making sure that you're using the data ethically and appropriately and responsibly, right? But those are 2 examples of places where it actively came up as part of the conversation.
Thank you. One of the aspects of the U.S. core data for interoperability, which is, something the WEDI community talks about a lot, may be a little bit of an alphabet soup for those of us who are not as close to that. But in the U.S. core data for interoperability is a requirement for the provenance of data. Where did these data originate? And in that case, there is possibly some enhancements to the sort of the clarity and the focus on attribution. Could any of the panelists talk about how attribution, and I would say how provenance of data plays into your strategies? Have you considered how getting more granular detail about who actually originated the procedure, performed the procedure, who originally diagnosed, made the referral, whatever aspect of the care it was? Are you looking at provenance as a key component of this?
Yeah, I'll start and then offer for Chris and Aisha to embellish. But so provenance was not explicitly called out, but there is extensive conversation and reference to the US CDI, as you point out, which it is part of. So I think there is a recognition of the importance of that. To some extent, by and large, the data used right now is claims data and provider EHR data, where you know where it's coming from. It largely is, you know, self-collected or through the billing systems, etc. But it's a very good point that as we move to broader data sets and more data included that maybe came from somewhere else, such as demographic data, that you know, that will be key. So there's sort of a roundabout way of supporting that and supporting the US CDI, but not explicitly.
I would
Thank
just
you.
say,
Go ahead,
oh,
Chris.
I was just gonna say, I think that just underscores, right, the importance, right, of that transparency and creating that trust, and understanding the methodologies behind this and the interplay between some of those underlying payment structures as well as those data as they both improve. That transparency is going to be really critical as part of those ongoing conversations.
Well, we've heard mentioned in a prior WEDI event that innovation moves at the speed of trust. And there's a core about what you've talked about, a glide path for providers, you know, risk corridors, stop loss protection, acts of protection against acts of God, you know, things that are just out of expectation, that need to be understood. But you know, could you talk about, you know, how how your collaboration is really reaching, I think especially through the AMA, is reaching the physician and giving that practitioner, and it may not be a physician, it may be another provider with a different degree, but giving that caregiver that sense that this isn't going to lead me to financial ruin, or this isn't going to lead me to a huge documentation burden, but this is a process that I can follow and that I can over time, you know, increasingly trust. Can you talk a little bit more about that trust component and what you're doing there? I think that's essential.
So
Perhaps Aisha, I would throw,
yeah.
Chris or Aisha, maybe I'll throw it to either of
So why
you
don't you
if you
start
would.
first? You want to start first, Aisha, and then I can jump in.
Sure. So I think it's like just throughout the playbook in every way that trust is critical, and I think you achieve that through and I started saying this at the top, through transparency and through collaboration and being open and honest about what shared goals are. And I think that is just something that you see in almost every single one of these best practices, that there's an element of transparency there. And I think as you're talking about what is the impact to thinking about down to the level of the individual provider, there is that one best practice that Chris quickly covered around what are the incentives to the individual provider. These arrangements are often at the level of a larger group, an accountable care entity. And so some of that trust is just about education and informing at multiple levels. It's not just that the accountable care entity enters into this, and you don't bring your providers who are doing the day-to-day care along in executing on the arrangement. You have to bring them along from the very start before you sign a contract, in terms of what the terms of the contract is, how it's going to change your day-to-day and care. And so trust is in so many ways around collaboration, repeated and ongoing engagement, and transparency.
Well, thank you very much. Oh, I'm sorry, Chris, go ahead if you would.
Well, I was just gonna say, I think there are a lot of the playbooks that, to engender trust, you have to have some of these actions that show like you're putting your money where your mouth is, right? So having, everybody wants data right now, but at least having data runs on a quarterly basis for certain components, right? Or how those benchmarks are actually calculated, right? And what data is going into that, I think also engenders some of that trust too. So not everything, right? Doing all 90 of these best practices is probably going to be difficult for everybody to do, especially right now, but picking and choosing some of those that really fit some of those pain points that I think shows that folks are trying to address some of these pain points and putting them into action, I think is a really critical part to continue that journey, right, of finding additional ways to reduce that administrative burden, right? Some of these different kind of pain points we continue to hear, especially on the provider level.
And I'll just add, just quickly, certainly our three organizations don't agree on everything, right? But we certainly believe that value-based care can truly improve quality and affordability while at the same time reducing burden on clinicians and broader providers if we are able to fully scale it. We ran this sort of outside the confines of contract discussions, right? So that we could foster an open and constructive dialogue. And we think it really represents balanced views across these different organizations for designing models. So we also hope that it's not it's not super ivory tower, but it's really demonstrated needs and validated actions. So to some extent, to Aisha, opening up with a checklist of these are things to think about so that you can have trust in reviewing the contracts that are offered to you, and for payers to design the models in a way that will be attractive to encouraging more providers to come into the programs.
Well, Danielle Lloyd, AHIP, Aisha Pittman, NACOS, Chris Botts from the AMA. This is a terrific discussion, or the beginning of a lot of discussions and a lot of work. But thank you so much for sharing your time with us today. And Brian, I am going to turn it over to you to introduce our next panelists.
All right, thank you. Our next session brings us to the federal perspective movement from fee-for-service to value-based care. To offer an update on the CMS Innovation Center's payment models, address the importance of technology and interoperability in the success of value-based care, and how WEDI can support and assist in the transition. We'd like to welcome Ellen Lukens, Deputy Director of Policy with the CMS Innovation Center.
You're on mute, Ellen.
You're on.
I'm so sorry, it's double muted. First of all, let me just excuse if there's any background noise because I'm at the Philadelphia Convention Center, but really appreciate you inviting me to be here today and giving us the opportunity to provide an update of where we are in the Innovation Center and where we're going. So, this first slide really talks a little bit about statutory mandate, but just to take a step back, really wanted to thank WEDI for having us today and for also being just a terrific sounding board as we think through some data-related issues. So I really wanted to start here because I think it's really important for folks to understand both our statutory opportunities, but also constraints. And our statutory authority really is to test payment models. And by that, we mean that generally folks come in on a voluntary basis, a provider or an organization, and they will agree to do something with us. And we essentially will evaluate how that works. And so we look at those participants relative to generally a set of controls and say, did the intervention we tested actually have the expected outcome? And so I think the reason that this framing slide is important is that we are constrained in terms of the test results being cost neutral. So our statutory mandate really is to improve quality and be cost neutral, be quality neutral and reduce costs, or in sort of the best case scenario, improve quality and reduce costs. So with that framing, next slide, I just wanted to describe a little bit about the types of models that we do. As many of you probably know, they're pretty heterogeneous and they may be things for things like a health condition. If you think about we have several kidney models, so really focused on end-stage renal disease and more recently even chronic kidney disease. We also have models that focus on an episode of care. And by that, an example would be a hospitalization combined with the post-acute care. So really thinking about that entire episode of care rather than trying to pay on a much more fragmented basis. We also have several models really focused on primary care, which is really central to a lot of our value-based care strategy. And we have worked on interventions in communities like rural areas, for example, the Pennsylvania Rural Health Model, and continue to innovate within Medicare Advantage and Part D. So we really have a very broad portfolio with a lot of different types of models. Next slide. So I did want to give you a sense of our strategy refresh and sort of why we did it and what some of the principles were related to that, and then go into some specific examples. I'm actually going to walk through 4 recent models with you just to give you a sense of 4 types of models that we're testing today, and then we'll talk a little bit about the role of data. So in terms of our strategy, in 2021, the director took a step back and said, have we really thought about what it is what are we trying to get to? What is our vision that we're trying to test the models in order to achieve? So instead of testing a lot of disparate models, really thinking about what is the overarching vision. And you'll see here the vision is articulated: a health system that achieves equitable outcomes through high quality, affordable, person-centered care. And then there are 5 pillars, and those pillars really are supporting that vision. And one of them is driving accountable care. So I was hearing a little bit of the previous conversation, and I think really when we think about accountable care, what that really means is a relationship with a beneficiary and a physician, where that physician has responsibility for the cost and quality of care to that beneficiary. So it really is having that relationship with a clinician. That to us is accountable care. The second one is advancing health equity. And that is really thinking about how do we take a step back in our models and think about, are our models helping close the gap in terms of equitable outcomes? So that has also been a priority for the past couple of years, really focused on, why is it that our models historically had tended to recruit more upper income white beneficiaries, and thinking about a more expansive view that would really be more representative of the Medicare population. And as part of that effort, we've engaged much more actively in our more recent models with federally qualified health centers. The third one, and I think this is really where you all have served as a sounding board and also where we've engaged more, is around supporting innovation. And part of that is really data related. And there's so many different dimensions of this. We'll talk a little bit about it at the end. But here really encompasses not only the data that we share to participants to help them perform in the model, but also thinking about the data we collect, how we collect it, and opportunities that we give providers to do things sort of in innovative ways with the Innovation Center. The fourth is addressing affordability. When we undertook this strategy refresh, we spent a lot of time talking to beneficiaries, to providers, to health plans, to states. And one thing that was really important to beneficiaries and that beneficiaries really reflected on was the need for and their experience with drugs and drug costs. And there were sort of 2 pieces of this. One was really the cost of the drugs, and the second was the lack of predictability. So I'm not including this as one of the models that we're going to talk about, but I just did want to allude to the Medicare $2 drug list. And we put out a request for information recently on that. That closes December 9th if you're interested in responding. But essentially what that does, it establishes a broad list of $2 drugs. And health plans can agree to provide those drugs to their beneficiaries for $2, all voluntary. But the goal of this really is to address that issue with predictability. So predictability at the pharmacy counter, that they really know how much the drug will cost. And the final is partnering. So we can't obviously do these models alone. As I said, in the majority of cases, these are voluntary models. So folks have to agree to apply and participate. That can sometimes be providers, it can sometimes be states, but we really do have to do it in partnership. And one of the models that we will talk a little bit about today is the AHEAD model. And that really reflects engagement we had with states where they wanted to do more and push the envelope even more and be more innovative. And so how could they sort of enter into a partnership with CMS that would better align Medicare and Medicaid? Next slide. So this is what we call a roadmap slide. and I can definitely share these slides with Chris and others to make sure that you can have them. But this was really meant to address one issue that came out in our discussions. And I think at the end of the last session, there was some discussion around transparency. This really reflects input we got that there needed to be a lot greater visibility into where the Innovation Center was going. That one big problem for providers, for payers, and for others was understanding what the Innovation Center was working on and sort of what the Innovation Center's priorities were. So as you know, we develop models and not all of them come to fruition. So we can't be 100% explicit about the future, but we try to be very helpful in terms of direction. So this is our roadmap, 2023 to 2030. And in the middle tranche you see there is really what we think about as our models, the model tests themselves. So I'm just going to refer to 2024. You'll see that we announced innovation in behavioral health and the cell and gene therapy access model. We also launched the Making Care Primary model, the GUIDE model, we will talk about GUIDE, the AHEAD model in the innovation behavioral health model. We are also developing concepts around population and condition specific models, around ACO model tests. That one we actually did just put out, a primary care prepayment model. Episode-based payment and specialty care models, we introduced the TEAM model, which is an episode-based model, and models to lower prescription drug costs. So you'll see the Medicare $2 drug list and the cell and gene therapy access model both relate to that. In 2025 to 2029, to give you a sense of what we're working on, we have some new model launches. The cell and gene therapy access model would launch in that period, the transforming maternal health model, the Medicare $2 drug list, they will all launch in that period. The new concepts that are under consideration, additional ACO model tests. So as you know, we have a large scale ACO model test that will be ending. And so at the end of 2026, so thinking about what comes next there, but also just really thinking about how do we offer opportunities so that we can meet that accountable care goal, that goal of having beneficiaries with a relationship with a clinician that really has accountability for their care. And so, we did the Making Care Primary model, which really helped bring along physicians with less experience in value-based care. And we also want to think about what ACO models can really help us capture more physicians that may want more risk or may want more flexibility, and how can we bring them into the program. The second one is specialty integration models. And for those of you working in specialty care, I would recommend looking at our specialty care strategy. You'll see that there's several components of that as we think through how to really better integrate specialists and primary care physicians. I think you saw that in the Making Care Primary, we actually established a payment so that when there's a referral and a consult and information sort of back and forth between the two physicians, there's a payment for that. So really building on that and thinking about how is it that we make sure there's a really solid information flow from specialists to primary care providers. How do we provide incentives for specialists themselves to really think about value-based care? And so that is all part of the specialty strategy, but something that we really continue to engage on. And finally, innovation in health plans and prescription drugs. So we continue to think through what is it that we can do. If you recall, there was President had an executive order and the cell and gene therapy access model was included, as well as the Medicare $2 drug list. And then there was one third one, which was accelerating clinical evidence. But we are actually thinking even beyond that, in this next phase, what would be those model tests related to prescription drugs. I did also want to draw your attention to cross-model priorities and external engagement. So cross-model priorities, I think you will be pleased to see that transparency, interoperability, and data sharing are strong cross-model priorities. Multi-payer alignment is also cross-model priority, and we think that multi-payer alignment will really enable better data sharing, and I'll talk a little bit about that when we talk about more in depth about data sharing. In terms of engagement and learning, we continue to engage stakeholders through the Healthcare Payment Learning and Action Network. That continues to be a really important venue for us to engage with health plans, engage with providers, and there really are work groups within that that help support our work and really bring folks together. to think about how to improve really the efficacy and of value-based care and also efficiency. And then we do listening sessions and webinars. And I do think that this has been very helpful to us. One thing that we've really focused on is engaging beneficiaries directly. And so not just focusing on providers, but also really understanding what's important to the beneficiary, really getting their perspective across the life cycle. When we think about models, understanding what would make this model successful from the beneficiary perspective. And so what does quality mean? Maybe it is actually a quality of life measure rather than necessarily a purely clinical outcome. So really trying to engage them as we think through the parameters of the model. Next slide. So as I said, I did want to talk through 4 new models just to give you a sense of the diversity of the models that the CMS Innovation Center is engaged on. But I think you'll see this theme of accountable care, really thinking about accountable care, and then also trying to address areas in which the current system is not functioning well. So there are 2 that really fall into the accountable care area, the first and the third, and the second 2 are really examples of current gaps in the system that we're trying to address. Next slide. So I realize this is a huge mouthful. We call it AHEAD, but it's the States Advancing All-Payer Health Equity Approaches and Development, AHEAD model. You can see why we only call it AHEAD. But essentially, the vision here is to partner with states. We have 6 states participating. And the goal is to partner with them to allow them to focus on population health. So when we talk about value-based care and getting there, how is it that we get there? In this model, we focus, we allow the state to really think about, if Medicare it's voluntary for the hospitals under Medicare to be in a global budget, but really thinking about the global budget to help the hospitals have predictability, and then greater investment in primary care and cooperative agreement funding for the state to enable them to build the capabilities to do this. And I think we're really excited for those states. This really is reflecting interest of some states feeling like they can move more quickly and more comprehensively toward that accountable care goal at the population level. And so I think these model tests will be really interesting and exciting as we see how they can really bolster population health within their states by combining Medicare and Medicaid, and in many cases, commercial payers. In terms of thinking about the success of this model, we will be looking at Medicare spending and Medicaid spending, but we will also be considering just cost growth in the state writ large. So I think that'll be a really interesting and enlightening sort of model test and also outcome measure. Next slide. So this is one of the ones where I said, in addition to really pursuing our accountable care goals, we think about how is it that we address gaps and issues in the current system. So this is the Guiding an Improved Dementia Experience model. This really, I think, is a very good example of where folks came to us and said the current system of dementia care is not working. And we went out there and we interviewed clinicians across the country that sort of had these programs that were homegrown, and we're trying to develop something that would be more of a comprehensive program around dementia care, where, I think the argument that some people are making is historically you were diagnosed with dementia and then sent home. And it was totally unclear what you or your caregiver should do. So the idea behind this is that there's care coordination and management, there's caregiver support and education, and there's respite care. So there's a much more holistic approach. The entity that is coordinating the care receives a care coordination fee every month for the beneficiary. And there's caregiver support and education to help the caregiver understand how they can help care for their loved one. There also is much more support for the caregiver to connect back to the practice or the entity managing the dementia care. And then finally, there's respite services up to $2,500 per year. And this is really to allow the individual caring for the beneficiary to make sure that they can take care of themselves over time and make sure that they're able to get a break to do things like do their own medical appointments. I think this actually is a fairly large model. There was much greater participation than we expected, which we were very happy about. And so I think over time, we will measure the outcome of this model. And I know some of you are quantitative people, and you may be wondering, how does this save money? And the largest contribution is from delayed nursing home placement. So that is one of the things we'll be measuring, but also obviously healthcare utilization. But we're really hoping and I think there was a question in the chat about quality measures and could we test its own or create some. We are actually using a caregiver burden measure here that we are actually working on as it's an existing measure, but we will be sort of testing it and developing it as part of this program. That was a good question about the quality measures. We generally try to use quality measures that are reliable and valid, just because there's more buy-in around that, but agree that in some cases, when you're thinking about what are those things that are really important to the beneficiary, trying to capture those over time and think about how to test those so that they can eventually fall into that category. Next slide. So shifting back to thinking about this accountable care goal, remember having a clinician who's responsible for the beneficiary. We did introduce ACO Primary Care Flex or ACO PC Flex. This really reflects a lot of emphasis on the primary care physician and the understanding that primary care physicians generally are underpaid. And so the idea is, can we get them a hybrid payment? So they're paid partially in a capitated basis. And the reason we think this is so important is that we want them to have more certainty, but we also want increased primary care funding so they have more time. So they have more time to manage the beneficiaries. So they can do more team-based care and they can be more proactive. So I think that this is, sort of one thing that has been recommended by a lot of folks in terms of really improving the lives of primary care physician and also improving the practice. I think we are optimistic that we will see improved quality through this program. But again, it is something that we are just starting to test, so we won't know for a couple of years. But again, I think our outcomes of interest really are improved patient satisfaction, reduced emergency room visits, and hospitalization. And that actually starts January 1, so it starts really soon. Next slide. Okay, this is the last one, and I think this really speaks to the heterogeneity. So this falls into a category similar to GUIDE, where it was really a problem identified. And the problem here was that states wanted to negotiate outcomes-based agreements, but it was very burdensome and operationally difficult to do so. So essentially, an outcomes-based agreement adjusts payments based on achieving the clinical endpoint. So there are these very expensive cell and gene therapies, and the states were willing to pay for them under Medicaid, but they wanted to make sure that they achieved the clinical endpoint that they were seeking to achieve. So for example, if they did not, they would get some form of rebate. And although many states were interested in doing this, they found that the upfront investment in articulating those outcomes and defining the agreements, collecting the data, doing the reconciliation seemed very overwhelming. So CMS is now negotiating the key terms and agreements between states and manufacturers, including things like cell and gene therapy market access and rebate payments. We are starting with sickle cell disease. This is all voluntary. So the manufacturers need to come in voluntarily and the states have to come in voluntarily. And we are in the process now of working on this model and structuring an outcomes-based agreement, and essentially states would have the option to come in and use the CMS outcomes-based agreement. We would take on the work of operationalizing it, which means that we would be the ones taking in the data, we will be the ones doing the reconciliation, and we will be the ones setting the terms of the agreement. Again, this is pretty different. This is really responding to innovations that are very expensive and also a one-time life-altering therapy. So they are well suited for an outcomes-based agreement, but it is a lot of work to execute one. So this, in the next couple of months, we'll have a better sense of participation, both from the manufacturers and from the states. And over time, I think, really the outcome of this is to understand increase in access and then also downstream utilization and avoidable things like hospitalizations and ED visits that are typical of folks with severe sickle cell. Any questions on the models before I go to talk a little bit about the data? Oh, question. Does it disincentivize? Yeah, I think, you know, that is actually, I think a concern for folks is if there's an outcomes-based agreement, are you sort of trying to pick just those best patients? I think that's less of an issue for some of the cell and gene therapies. And for some of them, you know, for sickle cell disease, I think in many cases, there's the standard of care that's still the traditional standard of care. And then these are really the folks that either have tried something like a transplant or are ineligible for some reason and then go to the gene therapy. I do think that these are transformative therapies and generally have relatively small numbers. So this particular gene therapy, it has to be customized to each individual patient. They actually take out your own cells and then put them back in. I think there's a really good question though, sort of what does this look like in the future when maybe you can do this in a way that's more off the shelf and less customized? I think those are really big questions. I don't think we necessarily know, or we don't know the answers to those. But I think right now we're really trying to see, like, can we actually structure one of these in a way that works for states, for CMS, and also for the manufacturer. And it's really with the goal of increasing access. The one other thing I'll say about this particular model is that because we're doing it through the Innovation Center, we have waiver authority, which means that we can waive certain things. So we are actually allowed to pay for wraparound services. And I should have mentioned that up front because it's a really important part of this model, but it's really hard for lower income folks to get some of these therapies because you often have to travel and they're often, costs associated with that travel. So we can pay for, through this model, the model can pay for the cost of travel. The model can also pay for fertility preservation services, which is particularly important in this population because a lot of the folks getting this therapy would be children. Next slide. Okay, so I realize there's a typo on the slide, so I apologize. But I did want to talk a little bit about the role of technology and data and value-based care adoption. And if you are interested in following up and have some ideas, we are always all ears. And many of you have probably talked to Will Gordon, who helps support us on a lot of this, as well as Todd Kaut. But I think we really believe that data and technology are foundational elements for providers to be able to participate and succeed in value-based care. And I think this is something that is so important to the Innovation Center. I think if you think way back when, I don't know if many of you remember this, but when we first started, we would send these huge claims files. And so we didn't have reports at all. They were just enormous claims files, and how difficult that was for most providers to understand at all what we were providing. And now, we do provide feedback reports that are much more robust and comprehensible and actionable, but there's still so much more we can do. I will also say that in our experience, our participants are in very different places along the continuum. And so, whereas I know that there's the holy grail of sort of what we would love for things to look like, and then there's the reality. So we tend to offer things in multiple ways. And I know this is probably horrifying to many people, but sometimes it's Excel spreadsheets, and then it can go all the way up to, APIs, FHIR APIs. So really exchanging data in very simple ways and then in much more complex ways. We also know that things are different in practice than how they seem like they sort of should be. And things can be much more complex than we think. And an example is compiling data between different EHRs. We understand how burdensome that is. So just the more we learn about it, I think the better we are at thinking through some of the issues. We still have a long way to go. So I'm actually going to start with data transparency. And we have a data transparency initiative, and I really like to promote this whenever I'm talking to folks because I hope people will use it. It is such an amazing resource. So what we've done is we've put all the data for our model tests now is available. So you can look, if you get a research identifiable application approved, you can actually look at what happened in our models. You know, obviously we did evaluations to look at cost and quality outcomes, but there's so much more to be learned from these model tests. And we, you know, obviously our job is to do models and to evaluate them, but we haven't gleaned everything we could from the models. And so we really are hoping by making all of these data available that researchers will really dig into them and pull out everything they can from the model test. So again, we've had some interest, probably not as much as we would have hoped, but we continue to put those out and are fully transparent about who participated in the model and also the data that we collected from that model test. We also have, and Will Gordon, who's our chief, really leads our technology, has developed a data sharing strategy. And something that is really helpful to us is that it focuses on decreasing burden. That is one of the main reasons, as I alluded to, you know, these are voluntary model tests. And one of the main reasons providers indicate not participating is because of burden. And a lot of that is reporting burden. And so we are very focused on reducing reporting burden in our models. We're also focused on making it as easy as possible for participants to send us data. And as I said, we generally offer multiple options for that so we can meet people where they are. There's also a data aggregation initiative. Some of you may be familiar with this. It really focuses on our multi-payer approach, where there are HIEs that are aggregating data. We are trying to be part of that now. So in areas where there's an HIE doing that, where we have active models, we're trying to be a partner and also provide the CMS data. And then an interoperability initiative, we can talk a little bit about that. That is really part of the enhancing oncology model. In the enhancing oncology model, some of you may be familiar with that we actually, through the Cancer Moonshot, met with the EHR vendors and agreed to collect USCDI data through the EHRs that we could use for the reporting of EOM. So we're really excited about that. I think it was a really nice example of a partnership. Not every EHR vendor agreed to it, but the vast majority did. And it's just really exciting for us because it means that it'll make you know, the data that much easier to report for the oncology participants. So again, really an exciting thing for the center. Next slide. So this is my final slide, and it focuses on really letting you know where you should go for additional information. We are always, again, happy to talk to folks and always welcome new ideas or, you know, even related to data strategy, how we can make things simpler for participants. We hear a lot from Danielle and Aisha and others on a regular basis about that, but really welcome your input. There's also a question and feedback mailbox we have around, it's the CMMI strategy inbox that we check on a regular basis. And if you're interested in receiving regular email updates, then, you know, we encourage you to sign up. You can also follow us, that should say on X. And I will definitely share these slides with the organizers, so you are welcome to have a copy. And with that, Chris, are we opening it up to questions? Or Mike?
Ellen, I think this is Denny Brennan. I think we've had some questions, but I think in the you know, spirit of time, we're probably going to move to our next presentation. Though I would ask those who have attended, I have a number of questions, but I think by the time I ask them, we'll be crowding out our last presenters. So I would encourage our participants to follow up with your questions and feedbacks at the email address on your screen. And visit the CMS Innovation Strategic Direction webpage. You know, read the white paper. This is tremendously exciting stuff. I mean, it's getting into precision application of value-based care. It's getting into, you know, engaging providers and dealing with a number of the complexities that these models not only address but create in and of themselves. And my kudos, Ellen, to the work that you and your colleagues at CMMI are doing. This is outstanding work. Thank you very much.
Thank you so much for having me.
All right, moving forward, we have a distinguished panel to talk about value-based care, about DaVinci, and how commercial plans and providers are working in the value-based care space. Joining us today are Anna Taylor. She's the steering committee chair for DaVinci and with Providence Health and Value-Based Care, Multi-Care Connected Care. Samira Singh, who's director of Population Health for Providence. Dr. Ben Pollack, who's a senior associate consultant with Division of Healthcare Delivery Research at Mayo Clinic. And unfortunately, Colt is not able to join us today, but we have a distinguished panel regardless. And thank you all for joining us, and we'll turn the floor over to you.
I believe Anna is going to start with a little background on the DaVinci project.
Yes, thank you so much. And thanks for having us here today. We're excited to be discussing how we are exchanging data using APIs as a part of the work we do under value-based care. I am the Associate Vice President for Multi-Care Connected Care, and so every day we are working on how do we connect data between our payer partners and our providers on a daily basis. And when I first started in population health, I found a problem, and the problem was that I couldn't get data to the point of care. And we were looking across the universe for solutions to figure out how could we best do this in order to get data to the people and our patients and our providers who are making those decisions every day. And we were invited to join a payer called Regent to trade data using FHIR APIs. And we started with quality data, and we used the DaVinci IG called Data Exchange for Quality Measures, DEQM. And that is how I became a part of DaVinci and the work they're doing there. So if you're interested in solving those problems yourself or with your partners in the industry, I encourage you to be curious about joining the DaVinci Accelerator, which is a project out of HL7. And there we work on how we are going to trade data back and forth between the business to business use cases in order to make us successful under value-based care in particular. Some of the other use cases that we are working on currently include risk-based membership, value-based performance reporting. We work on prior authorization, so all three end-to-end use cases, checking if an auth is required, what is the medical policy of the auth, and is it approved or denied. There are many more use cases for which we are working on under DaVinci, but DaVinci is something that anyone can participate in. You can be a paid member, or you can be somebody who donates your time in kind and helps contribute to developing what these handshakes look like in the future. And we do this mainly based on the FHIR HL7 standard. So I encourage you to join. If you'd like to be a part of that, we can give you information, or you can reach out to me on LinkedIn. But my friends who are part of this panel with me have been using FHIR APIs for some time now. And I see Samira out there who's been utilizing some of the DaVinci roadmap as we've continued to try to figure out solving this problem right now. So I'm going to hand it off to Samira next.
Hi, everyone. Good morning, good afternoon. I'm not sure which one it is anymore. Thank you, Anna. My name is Samira Singh. I'm the Director of Informatics at Providence. If you are unfamiliar with Providence by chance, we're a large health system spanning 7 states. We have 51 hospitals, I believe, hundreds of clinics, somewhere around 200 value-based care contracts. We are also members of DaVinci, as Anna mentioned. I will second that DaVinci is an absolutely amazing organization to get involved with, especially if you are in the value-based care space or in healthcare, data exchange in general, but value-based care especially. So our journey is similar to Anna's. We started out with member attribution, so the ATR implementation guide, with the understanding that one of the first things that we should do when we have a value-based care contract is have a standardized way to capture who the members are that are part of that agreement. ATR gives us that. Without member attribution and the FHIR specification or the implementation guide, we are all stuck in an ecosystem where we're exchanging data through, to our prior presenter's point, through spreadsheets in proprietary formats. And so we as a community try to do whatever we can to ensure that we're moving away from proprietary formats and into something more standards driven. We've also been successful in implementing clinical data exchange. It's unfortunate that Colt isn't here, as Primera was our primary partner with a CDEX use case. And essentially what we were able to do by leveraging the clinical data exchange implementation guide through DaVinci, or created through the DaVinci payer provider vendor partnership, is we were able to, in a standardized way, exchange clinical data to be able to close quality gaps for HEDIS quality measures. And that's been extremely successful, and we can talk about this down the road, but those are two use cases that we've been able to build over the past few years, where we've seen quite a bit of ROI within our value-based care contracts, a bit of burden reduction as it pertains to participation and insights within the agreements and data submission and so forth. So I'm super happy to be here to speak today, and thank you all for having me, and thank you all to the prior presenters. It's been a very enlightening day.
Amazing. And then I think we have Ben.
I just wanted to welcome Brian Wallace, who's from Centene, who's also going to join the discussion today as well. So sorry for the interruption. I just wanted to provide that FYI.
That's great. Hi, Brian. Thanks for joining us. Do you want to tell us a little bit about your experience trading data under value-based care?
Sure. Yeah, Brian Wallace. I'm currently Vice President of Provider Analytics Product at Centene. Prior to that, also lived in the shoes of a value-based provider group that took risk on Medicare Advantage lives. So have been on both sides, and I think something that has resonated for me throughout was what Danielle said earlier around as a provider, you don't want to have to pivot between portals and dashboards and proprietary sites. So getting to that single pane of glass, especially if you have when you have the patient in front of you, I think is where I spend a lot of time thinking how on the payer side can we facilitate that and make that experience better.
Awesome. And then I think I did not hear, but is Michael Patwell on today?
No, Michael's not on, but Ben
Okay.
Pollock from Mayo Clinic is on.
Awesome.
Ben, if you could introduce yourself, that'd be great.
Yeah, so it's good to be here, and thanks for having me. And I think a lot of the perspectives I heard today, I have some of the background on that, but maybe also a little bit different perspective from some of you. So let me give my background here to maybe set it up a little bit. So my name is Ben Pollock. I'm the scientific director for our Science of Quality Measurement program at Mayo Clinic. Really, what my program was built for and what my team does addresses a lot of the issue that many of you have noted today, where when we started this program in 2020 or 2021, quality leadership at Mayo Clinic was not getting fed up. I don't know what the right way to say it is, but continually, I guess, facing a barrier that our quality data, not necessarily our value data, but our quality measurement and all that data publicly reported in all the rankings, ratings, pay for performance programs is anywhere from 2 to 5 years old, as you've all noted earlier today. And so my background is in risk adjustment, epidemiology. And so my program was developed around, if we're going to get the hospital readmissions reduction penalty in 2 years, that data is happening today. Why don't we see it and recognize it? So what my team has done over the past 3 or 4 years is take the data from our EHR and build out a quality data platform of somewhere around 100 to 150 quality measures, replicating as close as possible whatever publicly available methodology documents are out there. And so I guess in relation to value-based payment, value-based purchasing, we kind of have the same issues. Quality leadership and administration at Mayo Clinic would echo some of the same thoughts we've heard here, is that not only is the data lagging a little bit, but we don't always know where our baseline period is that we're comparing to when we have to have these achievement and improvement thresholds. We also just practically can't really manage our patients by knowledge of their payer, right? Our physicians aren't checking who the payer is when they're performing a procedure or evaluating someone. Our administrators are certainly aware of that, but our processes and systems have to be the same for everyone. And so when some payers want specific or different initiatives just for their patients, that's not really something we can implement. And then some of the other issues, as noted with interoperability, we note that there's a lot of movement, especially in CMS, going towards ECQMs to reduce some of our burden and also being able to measure and risk adjust things more accurately. But quite frankly, that's kind of the other aspect of my program, is assessing the methodologies and biases in some of these methodologies. Risk adjustment will never be perfect. It's of particular importance when we talk about care episodes as well. At a hospital like Mayo Clinic, we find ourselves in a very unique position where we have a giant 1,200 bed hospital in a city of 100,000 people. People are flying to Rochester, Minnesota specifically for complex care, flying home 5-10 days later. Whatever happens the 20 days after us, they can consult us, but they wake up and feel bad. They're going to some other ER, some other healthcare provider, might not even be the same payer or the same insurance. So the issues with destination medical centers and very complex patients is something that my team works on, as well as trying to find better approaches to risk adjustment, or even just data interoperability, to where we don't necessarily have a grasp on what is our true readmission rate. A patient leaves our hospital from Minnesota, 10 days later, they're in an inpatient setting somewhere in California because that's where they live. That's not in our EHR. So there's things like Epic, Care Everywhere, some ways of getting at this data, but it's just a really incomplete picture and makes it difficult. So maybe pause there, and that's maybe lead to the next part of the discussion here.
Thank you, Ben. We're now going to open it up to the panel, and we know that we've provided the panel some questions. I know we're going to have questions from the audience, but when we listen to value-based care, and we listen to in both the public plans and the private plans, and the providers who work with populations covered by both, that there are so many intricacies and so many data points that need to be evaluated for purposes beyond, how good is the care, the distribution of sort of the cost of care, the attribution of cost. We've talked about the difficulty, Ben, as you raised, when sites of care are in an entirely different geography from where the original procedure. There's so many exceptions. But I know for a lot of us, one of the questions we have at the center of our minds is, are we making progress? We know Medicare is pushing it. We've heard from Ellen about what CMMI is doing, but you guys represent innovation among private payers and health plans, and we would love to hear from you about what you think is really, where are we today in terms of value-based care from your perspective? Have we advanced further than we were, say, in 2020, 2022, or do we have to look further back to see that we've made real progress? And I'll turn that over to anyone who wants to take this first stab at that question.
I can start with this if that's okay. So
Sure.
I think it depends on what area you decide to focus on, right? Like if we talk about prior authorization and the burden reduction associated with that, have we made progress? Absolutely. Have we made progress to the point that clinicians think they're going to have a seamless end-to-end prior auth solution by 2027? TBD, right? We know that right now, the focus for a lot of our vendor partners is that first piece of, is a prior authorization required? If we talk about value-based care in general, or the way that I think about a payer-provider relationship within value-based care for our Medicare Advantage, Medicaid, commercial plans, and we say, have we made progress on sharing enrollment data? Depends on which plan you're asking, right? So for most health plans, I would say that the answer is no, because there's this stigma around innovation and building solutions that are not mandated. And so something as simple as implementing ATR as a foundational use case that has a baseline for what kind of information should be exchanged through what modality, it's not at the forefront for a lot of plans. And then I think you have to ask yourself, what does that mean for providers? Well, providers are still going into portals, downloading Excel documents. They're getting lists through emails. We still are maintaining SFTP servers and so forth. And I would say that as much as we talk about burden reduction, we always focus on things that are in mandates, right? And not how do we reduce the burden of the administrative staff, also supporting the scalability of value-based care. So on that front, no, right? We're not making as much progress. A good chunk of my time is spent talking to our payer partners saying, here's what you send us right now, and here's how that can translate into FHIR, and here's a seamless opportunity to do this, right? And sometimes it's great, and we really value our partnerships, but it's also usually great with the bigger health plans that have the budget and the teams to be able to implement this. The second piece here is around quality, because we all talk about quality measure development and so forth. And I may have a bit of an unpopular opinion around this, because I think a lot of the times when we talk about clinical data exchange and quality, there's this notion that you must remove the provider organization from the equation. And what I mean by that is, if we look at national initiatives, state initiatives, it's all around how is the data from the EMR transferred to that payer, to that governing body, and so forth, and not so much around what role can the provider play in exchanging the clinical data and ensuring that they are good data stewards, that they're representing their patients in an adequate way, and that they know exactly what kind of information is being exchanged and what that information is going to do downstream, right? We don't typically have those conversations because quality data is synonymous with clinical data, synonymous with HIEs, and so forth. And so I think really what we should ask ourselves in that space is, as much as we talk about things like TEFCA being a national on-ramp for interoperability, what is that national on-ramp for getting providers more involved? And I think saying it'll create additional burden for providers is a little bit of a cop-out, right? And saying like, oh, providers have no space in the VBC arena when it comes to administrative maintenance. And I think that's unfair to both the payer and provider, and that we would get much further in quality measurement and quality data exchange if we have the right providers at the table to be able to take charge of their value-based care contracts. The next piece I would say is, are we getting further ahead with bidirectional data exchange, right? So that second piece of getting the payer data back to the providers and ensuring that it's actionable. Ben, I love that you said that there's such a time lapse, right? I know a lot of other people have said this as well, in the kind of information that you get. Well, a big component of being successful in value-based care is having the right information at the right time so that it can influence action. And a lot of the kind of data that providers get now is lagged data, financial data, right? Gaps in care. As soon as you start expanding from 1 to 2 to 3 to 4 value-based care contracts, those gaps in care reports have to have some commonalities between them. Otherwise, you can't use them, right? You're spending more time trying to understand the data that you're getting than you are implementing solutions for those things. So overall, I would say, Danny, to your question, are we getting ahead? Yes, where there are mandates, but no in areas where there's a ton of ROI, a ton of potential impact to patients, a ton of opportunity to further scale involvement in value-based care. And I think we should all ask ourselves why and how we can create that on-ramp to have more providers at the table here.
I love that, Samira. I love that so much. I want to answer your question, Denny, from way up here, thinking about being in value-based care for 9 years now. But if you start with NextGen and the first CMMI model that was made to make this happen, I think there were a lot of successful practices, and one of those being Physicians of Southwest Washington, which we are affiliated with as MCC. And they really figured out the sauce that it took to be successful under those models. And they were not a health system. They were a group of providers that came together to do this independently. And then during the pandemic, value-based care was winning. Nobody was utilizing healthcare. It was a place of opportunity, and I think we saw some strides in some large 4 times the amount investments in healthcare and in healthcare services that was going into helping us drive forward with value-based care. But post-pandemic, we've been in financial situations that have not enabled us to drive value-based care as much forward as the momentum as it was pre-pandemic. And I think some of the reasons why is because we go back to what makes us successful. And as Samira shared, we're still not getting the data we need to be successful in value-based care at scale, and therefore we're going to do the things like fee for service that keep the engine going and funded so that we can make the baby step investments in value-based care as the financial models slowly change. But it's something that we do need to come together, ask the whys like Samira shared, to be able to move it forward faster, because our biggest thing that holds us back is the ability to get data to where decisions are being made. And that's just plumbing. And I say just as a LOL smiley face, because we can do this if we all decide and choose to do it together. And Da Vinci is one of those communities we do that in.
Brian, you're on the health plan side. Talk to us, round this conversation out.
Yeah, I would, to answer, your question, has progress been made? I think as Andrea showed in her session, from the measurement of members or lives participating in value-based arrangements, I think that has shown improvement and getting closer to those goals that HCP Land has set. I think on the technical side, the focus has been, are we meeting the contractual obligations of data sharing that we've established in these contracts, and less so on so getting the data across into the doors of the provider offices, but then leaving it up to them to put it all together, or through either a vendor or through a team they may need, especially if they have multiple payer contracts. So I think the focus is starting to shift to how do we adopt standards and do more so that these providers will want to remain in these value-based contracts with us, especially if you aren't necessarily the biggest payer on their panel. So enabling that success via the data that we have, so they can take those appropriate actions at the point of care and understand what levers they have in their value-based arrangements that they can pull when things might be going off track.
And Ben, from your vantage point at the Mayo Clinic and in your capacity in organizing the quality measures and looking at how value-based care can be implemented for an organization like yours, where have you made progress and where have you not?
I would say from a glass half full perspective, I think there's really three kind of related areas as I'm jotting down notes here, where I do think we've had progress and it's good momentum. And those are kind of around the consistency and literacy and quality reporting, and our physicians, providers knowing that they're going to be held accountable for their outcomes now and forevermore, and it's only going to get more and more important. And so we think of things like even like the CMS star rating or some of those pay for performance programs. Those measures really haven't changed over the past 5 years or so. So everyone knows, 30-day AMI readmissions, we need to make sure our rate is low. We need to make sure hospital-acquired infections like CLABSIs, and you have the same conversations from quality leadership to our providers over and over again for the past 5 years, kind of gets nailed into their heads. Here are the things we care about. And so there is accountability. There's progress in that aspect. If something new comes along in one of our, we have a new value-based purchasing agreement and there's some measure that's important, I think it's very easy to get people on the front line on board with improving whatever that measure is. From the glass half empty perspective, I would say I don't know that we've made a lot of progress in developing measures or data streams for things that patients actually care about that might be more important than some of the outcomes we're measuring now. So just to take one example, I look at something like US News measures the 30-day mortality rate of our orthopedic hip and knee patients. Those patients have less than 0.5% chance of dying. All they care about is, when are they going to be walking again? What's their quality of life going to be in 6 months? So those are the things that, they're hard to capture, obviously, when you're using claims-based measures. But that's, I think, where the progress needs to still be made.
We're moving closer to claims and clinical. We're getting there. We have a deadline. Samir, you mentioned it's good. How well we hit that deadline remains to be seen. But we have a deadline, and the focus has been, it seems, first and foremost, because it's probably less complex, is on burden reduction. You know, prior authorization is a big piece, and Anna and Samira, you guys are national leaders in speaking to that. But quality measures it gets a little bit closer. When you start talking money, it gets really, really complex. And how, you know, who gets paid to demonstrate what level of quality. Can you talk a little bit, and I would direct this to any member of the panel, but if we hit the 2027 goal, and we have burden reduction with prior authorization and the exchange of quality data, we have demonstrated use of that across certainly a subset of the payer provider community. How will that, or will that not, accelerate your current efforts to move value-based care? Do you think you have to nail burden reduction first to make the next major step, or are you able to move in parallel with that?
I can start with the first comment to that question, which is, we didn't start with burden reduction to begin with. Actually, the first start is in value-based care. The most important thing is to know who you're responsible for within the contract. So there is a use case called ATR, or risk-based membership, which is essentially a group of people that you're responsible for between that payer. So we initiated our buyer journey not with burden reduction, but ATR and quality exchange, because the pain points for value are getting supplemental data across the line. Prior authorization is a use case that serves the fee-for-service world. So if you're looking at advancing value-based care, burden reduction is not something that's going to do that initially, like immediately, like quality would, okay? Quality is gonna take a pain point away immediately. Burden reduction is step one to adjudicating a claim real time, which would then give value a huge advantage in the marketplace over our older models of fee-for-service. So burden reduction is a long-term game in order to get to a claim that could be more efficiently and effectively adjudicated, so that the provider and the patient can make real-time decisions about their care based on their coverage, based on the cost and the best site of service and the situation for them, right? It becomes more personalized when we have more information to take that into account. So no, your journey does not have to start with burden reduction. You should focus on it because it is the foundation for the future. Step one is really get the people you're responsible for, because all the other things are going to utilize that utility use case in place.
Thank you. That was very helpful. Samira, what are your thoughts?
Yes, I'd like to add on to that because I really love everything that you said, Anna. And I was sitting here thinking about like our current conundrum, right? And how do we get as many payers and providers into this space where they have an interoperable ecosystem where we can exchange data in a more real-time basis and so forth. And I go back to your question then, Denny, like, would I start with burden reduction as the first use case? To what Anna said, I also wouldn't. Providence also did not, because we started on this journey through a value-based care space. But will this help catapult more participation in, FHIR-based exchange, in helping payers and providers build a more interoperable ecosystem, knowing that not everything happens within an EMR, right? Especially if you're participating in larger programs where you have high performance networks, clinically integrated networks, you have different EMRs, different clinics, different methods of integration and so forth. Yes, it will catapult that. And here's why. And I always go back to like real world examples, because part of value-based care is oftentimes cost, right? Depending on what kind of contract you have. But if you have a total cost of care contract, you need to be very, very cognizant of where your members are going, what kind of care they're getting, what the incurred costs are, and so forth. And so you oftentimes need claims data. And so back to your comment about the 2027 deadline, Provider Access API has two components, a clinical component and then the administrative financial component. And although it is not mandated that payers share financial data through that administrative component, it is highly suggested, right, especially if you have a value-based care relationship. And so where I see this really helping in the value-based care ecosystem is one, payers and providers who maybe don't have the member attribution or clinical data exchange or whatever it may be use cases, they may be able to kind of dip their toes into this process and say, what do I do if I get claims data? What about if I'm using a vendor that currently allows me to more in real time calculate spend, cost, et cetera, as part of a contract? How do I integrate this FHIR data that's going to be available through the standard API into their process, right? Great, I'm able to integrate it. What else can I do with this data? Can this help me in calculating quality measures? What about that clinical arms and so forth? And so I really see this as an opportunity to have payers and providers and vendors start thinking about FHIR data as a kind of as a baseline, right? And kind of start saying like a FHIR resource is a FHIR resource, regardless of what profile you put on it. You can use this for so many other use cases than what it was intentionally intended for. And then I'm very, very optimistic that once the lens switches to thinking about burden reduction as kind of a starting point to these other use cases, that we'll see participation in all those other areas expand, right? Because it's a normal, I would say it's a normal question to say, where do I go from here? I've implemented prior authorization, I have provider access API. What can I do with this data? How can this help me along my journey? And I do think that having that standard data set is going to be pivotal for expansion to other use cases. So it's okay if you don't start with ATR. Both Anna and I highly suggest that you do, but if you wait until the mandates and then you build from there, like it's a wonderful starting point.
The message is just get started. Start somewhere.
I'm
Be
a big
curious.
I'm a big fan of the just get started school of
Yeah.
implementation. Brian, what about from your perspective? You know, looking at, you know, the use cases that you see as building trust, momentum, you know, bringing this value-based care train further down the track.
Yeah, I've heard that, you know, building trust mentioned a lot today. And from any of the seats I've been in, that building that trust is foundational. So I know historically, some of the abrasion or friction points may be a claims file doesn't end up tying to a financial statement in VBC, and then you get fingers being pointed on, well, you know, what's right, what happened here, what was excluded or included. So as much as we can do to create that consistency of the data and standards and explaining how we're looking at it, all the better. Then the providers spend, you know, less time analyzing necessarily the financial statements and the contracts and more time looking for those insights on patient care and where they can move the needle.
Ben, from your vantage point, you know, we're moving to quality in real time. You know, we're getting there. We're not there yet, but we're getting there. Can you talk about, you know, what that means for the Mayo and how that might change clinical operations on the ground?
Yeah, I think I would echo what Anna said. Just the first step is the most important. I certainly agree that burden reduction is a long-term goal that can also be like one of the last dominoes to fall. Just thinking through Mayo and other institutions that have provided relatively good quality care in the past 5 years, despite the pandemic. I'm sure it's the same at other places where every, you know, monthly quality leadership meeting or clinical practice committee meetings, we're talking about the burden of, you know, it's hard to keep our quality up on this front because of these resources. But we've been talking about it, you know, every month for a year, and we'll still be here next year. We'll still be providing good quality next year. We'll still be here the year after. So you kind of find a way to muddle through and just continue to make things happen. So especially if there's a light on the horizon of, you know, we know the burden will be reduced at some point in the future. We'll have more real-time data. We'll have some of these things we've been asking for. I think that makes it even easier to, you know, sprint through the next 2 or 3 years rather than, you know, resign ourselves to having these same issues 15 years from now. So we've had these issues for a long time. We've made it through, and I think, you know, there's more of a light at the end of the tunnel type of thing. So I think starting somewhere other than burden reduction is fine.
What, you know, one of the undercurrents of the conversations we've had today is this many-to-many challenge that we have. many health plans, many providers, whether they're hospital-based providers, whether they're in groups, whether they're independent practitioners, whether they're post-acute. The universe is very large, especially on the provider side. And in that undercurrent is this theme of, or this sort of calling out of collaboration. Can any of you as panelists point to? I know some of this is probably self-evident from the work that you've presented to WEDI before, but for our audience today, can you talk a little bit about how you've harnessed collaboration and where you see gaps in harnessing collaboration to deal with, as Janice Karen points out in her question, there are so many metrics and so many rules and definitions that require this kind of coming together and doing it collaboratively, that we certainly believe in our neck of the woods. But we'd be interested in your perspective on and your experience with collaboration helping you, or the lack of collaboration hindering you. Do you see organizations in your market saying, this is proprietary data, this is my data, I'm not going to share these data with anyone? Or do you see people asking to collaborate? Are you sensing a change in the way communities and ecosystems are going to be looking at these problems, as opposed to trying to deal with them one enterprise at a time?
I can start with this if the group's okay with that.
Sure, Samir.
So the first question around what is working, I think we can all acknowledge that, to the point that was made earlier, if we look at the way that value-based care contracts are structured, oftentimes payers and providers meet the contractual obligations by sharing the stipulated data, not necessarily sharing data that is usable, that is going to result in some sort of action. And so I think both payers and providers can agree that something needs to happen. And so from that perspective, what has worked for us at Providence is, and I may have talked about this a few months ago, is and we have very strong relationships with our payer partners, right? So we set up monthly interoperability meetings or form a tiger team to tackle a specific issue or whatever it may be. But those are one-to-one conversations. And the benefit of those one-to-one conversations is really we get an opportunity to teach each other, right? And to learn from each other, and to say, when we're exchanging quality measures or data relevant to quality measures, whether it be packaged or supplemental clinical quality data, here's what that could look like. And here's what standard that could meet. For example, Anna mentioned that they implemented DEQM, right? That packages up quality data and delivers measures. We decided to use CDEX because most of our payer partners wanted just supplemental data that they can then run through their HEDIS engines and so forth. But when we embark on that journey with one payer partner and we leverage a standard that we can then reference and say, here are the data elements that need to be included, here's what that looks like, here's what the exchange mechanism, here's what security looks like, it's a lot easier than to take that conversation and scale it to other organizations, right? So I think that the one good part there is, by building these strong partnerships and by leveraging standards, we're able to build a process that works with one kind of payer and then replicate it with others. And the same thing is true for other payers, right? If they implement something with Providence, they can go to other providers and say, here's what we found that has worked, here's the ROI associated with it, here's the burn reduction component, and so forth. So all of that has been wonderful. And maybe I just answer that first piece, and then everyone else can, and then we can talk about the components that are not working, so we're not flipping back and forth.
Okay, Brian, go
Yeah,
ahead.
I completely agree with Samira. The power is in the partnership. Payers, can't assume to know what the provider needs, and so it's getting to the point where you're not talking about attribution or assignment issues or arguing over members or claims data, and moving past that to the bigger rocks around the standard formats, the frequencies, all that can be improved, with those monthly operating meetings and the one-on-one conversations, and just as they can Samira can more easily take that to other payers. On the payer side, once we have those partnerships, we can take what we develop there to the other providers. So it's a strong back and forth that kind of feeds on itself once you get the conversation to that point.
Ben, just, and I see Anna, you've got off mute, but I beat you to it. So, Ben, Minnesota has some of the leading provider organizations in the country. And Mayo is certainly by many measures at the top of that list. Are you engaged in collaborative efforts with other providers within the state to sort of streamline and coalesce around how to collaborate with the payers in your marketplace? Are you doing that, or are you doing that as an institutional initiative?
We sort of do that, not necessarily for Minnesota, but we have our Mayo Clinic Care Network, which is something like 80 or 90 other hospitals across the US, a few of which are in Minnesota. And we do share some of that learning, some of the ways we benchmark and measure ourselves on different things. We share some of that analysis with them, but it doesn't go as far as to where, we build all these dashboards and predictive tools and real-time measurement from our EHR. It's not like we're sharing that with Epic, or Epic is sharing that with our care network. It's kind of still segmented in that respect. But I mean, that would be my biggest pain point too, is even with some of our providers, the things we can and can't do in Epic. And we have some of our own risk prediction models and things that providers would use at the bedside, where there would be a cost, or Epic would gain ownership if we share that with Epic, and vice versa. Some of the things we would like Epic to turn on within our system, there's a cost to that. So that would be the collaboration that I think needs to improve the most from my aspect.
Anna, I'm coming back to you.
You're
Working my
coming
way back to you.
Number one,
Yeah.
I'm applauding Ben for his statement there. I think we all get stuck there the last mile sometimes can be the hardest part of it all. As far as, I often get the question, we have done burden reduction with Cambia and do a purifier exchange using that, which has gained us a lot of efficiencies. But I've been questioned around the nation on, can you repeat this relationship that you've created between the two entities? And I think you can. I think what we have to do as humans, not as tech people trying to put things in place, is to create a relationship just like you would any other, and not one based on negotiating rates, but rather trying to share an operational business process that's going to make both of you better and give both of you a better product for your members, for your patients, for your group of people you're responsible for. So no matter what, forging new types of relationship with payers is absolutely possible. I think it's about finding the right person in the organization, just like any other relationship would be, who's going to forge that with you and create that space in order to do these new things together. Because once you get to parity on showing all the use cases, the numbers this sells itself in creating a culture that makes collaboration beneficial between the two entities, no matter if you're negotiating rates. We had news articles written about us that were not great because we were negotiating rates with payers, but yet we were still trading, our data in different ways and trying to solve problems that really none of us should be competing over, because getting data to the point of care so that we can care for you better, for your mom better, for your kids better, is something we don't need to be competing over. So I think collaboration is something you make a choice to do, and it's absolutely something we can recreate. I think that a lot of the friction that I see when I try to create that in with other payers is I haven't quite found the right person that's going to understand what we're doing and take it all the way from point A to point B. So it's also about getting some data literacy to the front lines and the people who are your provider relations team to understand what this does for everyone and get that work going. So I think that the collaboration is there. We need to create the digital literacy to do it, and then we have to make the choice to do it.
All right. Janice asks, are you focusing primarily on one-to-one conversations and relationships? Or and that sounds like the answer sounds like, yes, you are. That's how
Yeah.
you build the relationships, but that might provide momentum when others see how effective the relationship, the one-on-one relationship was the first time around. Is that a fair
Yep.
statement to make?
That's a fair statement. I will say we're also trying to scale that by creating a space where we can all get together and kind of do matchmaking in like sharing a monthly meeting about interoperability, and whoever wants to come talk about it. So it's like what do you call it? Like where you speed date.
I was going to say speed dating. That's what I was thinking.
Nice, Jenny. You and I were on the same wavelength there. It's like speed dating for trying to find those matches, because yes, I think that we could do this at scale, but I absolutely think based on the length of time we've been doing this, it's one at a time, and then it becomes infectious in a very positive way for serving communities.
Any final comments from any of the members? Samira, I see you getting ready to make a comment.
My face is just a tell-all. Yes. So I want to go back to what Anna said about one-to-one and the reason behind that. And we talked about trust a lot, right? And we can talk about TEFCA and the trusted exchange framework and common agreement and all of that stuff. And there's a lot of push towards building an environment where payers and providers and vendors do not have to focus on point-to-point connections, right? And that will happen eventually. It's just that it's a little difficult to push that so strongly right away when value-based care in its nature, in the way that contracts are structured, it's value-based care contracts are typically structured as a payer provider or a payer multiple provider agreement to do something for someone, right? And so if you take that and you transfer it into a different ecosystem, it feels like that relationship gets a little muddied, right? What kind of data are you getting? Where? Who's responsible for what? Who's the intermediary? How do you support the technology? How does this security that you've come to know and love like transfer into this new environment? And so I think there are a lot of questions there that we need to answer in order to be able to support a larger web of exchange between multiple payers, providers, and so forth. And the way that we start on that is by building things according to standard, right? Because even if we say everybody trusts everyone and we're going to exchange information, in what standard? Using what? Proprietary processes? That doesn't work, right? So I just want to say that like all of the work that we're doing right now to be able to exchange data in a standard way, to be able to have a common understanding of what things like gaps in care reports are, how you calculate quality measures, who the measure steward is, all of that stuff, right? That's just laying the foundation for building a more interoperable ecosystem. So we're getting there. It'll just take a bit of time.
This takes a bit of time, but healthcare 2 years from now is tomorrow. In our experience, right? It seems to be that way. I had to change microphones. Do you hear me okay? Okay, great. Any other comments? Brian, from yourself?
No, nothing specific. It was great hearing the conversation, and I will plug, if you're looking for speed dating forum, the payment models work group monthly meetings we have on the Tuesday, 3 to 4 are a good spot.
We're going to change the name of that work group. I can hear it now.
We are.
It's going to be the speed dating payer model work. Well, I want to thank everybody for a great discussion, and thank you for such valuable information and for the spirit with which you convey it, which is lovely. And Michael, with that, I'm going to turn it over to you as we get ready to wrap up.
Danny, thank you so much for a fantastic time. You're a fantastic moderator. Along with Brian, thank you for stepping in and helping us out. And thank you to all our speakers. As we conclude today, be sure to visit wedi.org to learn more about our November spotlights. We still have a couple of sessions to go in the year of 2025. So in November, maximize plan ROI on mandated APIs, key considerations for operationalizing CMS Rule 0057. That's November 18th. It is free to the industry. And balancing patient data sharing and privacy, navigating interoperability challenges in modern healthcare. That's a WEDI Health Equity Workgroup event that is exclusive to WEDI members, and that takes place November 21. For everyone, on behalf of WEDI, thank you very much for attending, and we'll see you soon.